Good morning. We are about to start. I want to invite all of us to be seated. Just to really appreciate each and everyone who already made it. We now wish to invite all of us so that we can begin our long-awaited day. So good morning, esteemed doctors and all our distinguished guests. My name is Walter Gada. I'm the Key Accounts Manager at Zydus Life Sciences. And I'm indeed humbling moment for us here today, and we're grateful that we've made here for the inaugural Zydus Care 360 Conclave. So let's appreciate each and every one of us. Let's appreciate. We can give a round of applause for everyone for making it. It's our first and ever, and so we are really looking forward to it this day. So as we gather here today to advance our scientific knowledge and share clinical experiences, I will request us we begin by honoring our nation and our values we uphold. So at this moment, I want to kindly, if we could stand, and then we have our national anthem. It's our symbol of national unity, right? Yeah, so just a minute as we're going to sing the national anthem together, and then we are going to continue. Thank you so much. We can have our seats. I know we always do the East Africa anthem, but I think today we just do the national one. I see it's normally nowadays too, every corporate conference they do both the national one and the East Africa, but they say tusiguze mlima, so tutaguza hiyo. Thank you so much. So now we want to again watch another short corporate video that will be highlighting Zydus Life Sciences and its shared mission and commitment to shaping a healthier world. So wherever we are, we're just going to have a short video that we're going to play short there. That's where now we do a round of applause for that journey for Zydus Life Sciences, its shared mission and commitment to shaping a healthier world. And thank you so much. At this point, before I introduce the next speaker here, I just want to give us some house just keeping rules. Myself, Walter, I'll be the MC, I'll just be here. In case of any assistant you might need, I'm there. And also at the back, we also have Moses. I know also will be supporting us in anything that we might need in regards to this. The Moses again will be of great help to us, okay? So it's now my great pleasure and honor to invite Mr. Vinit Shiva, the Vice President and the Head of Africa Cluster, Zydus Life Sciences, who will unpack and share insights on Care 360 Conclave. Let's give a round of applause for Mr. Vinit Shiva, who's coming to speak to us.
Thank you, Walter. Very good morning, ladies and gentlemen. It is my distinct pleasure to welcome you all to this Care 360 Conclave, an event proudly organized by Zydus in collaboration with the Kenyan Association of Family Physicians. Karibu sana. This also marks a significant milestone for Zydus as our first event of this magnitude in the whole of East Africa. And we are thrilled to have you all join with us for this event. Now, I'm not sure how much do you know about Zydus, but I intend to explain a little bit about this company. You might have seen that in the corporate video. This is a company which got started way back in 1952 in India, just after India became independent. There was a kind of clarion call by the then first Prime Minister of India that we should work towards self-reliance in healthcare. And one of the pharmacists from Ahmedabad, Mr. Ramanbhai Patel, was the one who started this company in the name of Cadila Laboratories. It became quite big in India. In around 1980s, it was the second largest company in India. And, India is a massive pharmaceutical market. In 1995, it got restructured completely, and that is where Zydus was born. At that point in time, it came to be known as Zydus Cadila, and the holding company was Cadila Healthcare Limited. That is where the true journey of Zydus started. While it started as a generic company, the senior management at that point in time had earmarked investments in three critical areas. The first area was vaccines. At this point in time, we have some of the biggest vaccine portfolio globally. The second investment they had earmarked was for new chemical entities. As we speak, we already have a new chemical entity in the name of saroglitazone, which has been launched for diabetic dyslipidemia. The third line of investments was in biologicals in the form of biosimilars. And ladies and gentlemen, we have quite a few biosimilars which are first in the global market. Notable amongst them is adalimumab, the biosimilar of Humira. Apart from that, there have been quite a few innovations which has come from Zydus portfolio. Notable amongst them is desidustat for chronic kidney disease-related anemia. And of course, we were one of those 71 companies globally who also did quite a bit of research to discover, the COVID vaccine. In 2022, which means just a couple of years back, the company rebranded itself as Zydus Life Sciences, thereby encompassing anything and everything that is required for healthcare or for wellness, as a matter of fact. Our color, if you see, you can see the colors that we have on all the banners over here. It's purple and teal. it's not an arbitrary choice, but was carefully selected to highlight the Zydus vision of innovation and purposefulness. Today, Zydus Life Sciences continues to thrive, driven by a mission to create healthier and happier communities worldwide. Incidentally, this mission aligns seamlessly with the principles of universal healthcare, which emphasizes the importance of primary care and family medicine. Universal healthcare begins at the level of primary care and family medicine. They are at the forefront of championing preventive care and addressing the burden of non-communicable diseases through early diagnosis and intervention. This is the reason this event could not have been conducted without the collaboration of Kenyan Association of Family Physicians. In an era dominated by cross-sectional studies, family medicine stands out as the only specialty offering longitudinal relationships. This allows for a deeper understanding of patients' histories, comorbidities, lifestyles, social contexts, ultimately leading to more effective and personalized care. Family medicine is uniquely positioned to play the crucial role of fostering multidisciplinary collaboration between specialists and family physicians. Family medicine and primary care physicians are best poised to ensure comprehensive care that covers the health of the entire family. This approach goes beyond the mere absence of disease, aiming for overall harmony and well-being. Built on this philosophy, Care 360 marks the beginning of a platform, and I repeat this, it's not an event, it's not a one-time event, but God willing, it marks the beginning of a platform for sharing experiences and knowledge with the larger goal of developing policies and informing decision-making in family medicine. We look forward to the insightful discussions and collaborations that will emerge from today's conclave and many more to come. Together, we can pave the way for a healthier future, starting with the foundation of primary care and family medicine. Thank you for being here and for your commitment to advancing healthcare. Asante sana. I'm not finished. Sorry, I am practically, but let me take this, it's my honor and an absolute privilege. Let me take this opportunity to introduce the chair and moderator of today's scientific session, Dr. Joy Mugambi. Dr. Joy Mugambi, who is a consultant family physician, Director of Health Administration and Planning for Nakuru County, Vice President of Commonwealth Medical Association, and of course, Chairperson of Kenya Association of Family Physicians. So ladies and gentlemen, Dr. Joy Mugambi.
Thank you very much for the introduction. Good morning.
Good morning.
It's so nice to see you all after almost 4 months since we last had an engagement. We had a conference in June, the first week, and Zydus was one of our champions, helping us get through an African conference. It was not just a Kenyan conference, but we are truly honored to be here to start this 360 care conclave discussion. And when Zydus reached out to us, we were like, yes, we love masterclasses, we love having capacity building sessions for our members, and we'd had quite a number of engagements in the past years that have been there. We've had a masterclass for sickle cell, we've had a masterclass for vaccinology, and those masterclasses have impacted not just our members' knowledge, they've also impacted policy changes, engagement with our community of patients, and ensure that we have better practice within our practices. We hope that this engagement that we are now having as primary care providers, supported by our multidisciplinary teams, when you look at the scientific team that will be presenting here, they are not just family physicians. They are coming from various specialties and with a purpose, because we work in a multidisciplinary team. We work with various other specialties to be able to engage our clients. And this year we really wanted to look at it holistically, looking at different components of health, from the heart to the lungs to the skin, and ensuring that we offer the best in terms of how we engage. In addition, we are now in an era where we are implementing primary health care in our various counties, the 47 of them. And proudly so, we have a family physician in each of the 47 counties. Not like before, where we used to say family physicians are in Nairobi, Webuye, where family medicine was really embedded. We now have a family physician everywhere. I think that calls for a clap. We are, as KFP, key at co-creating programs that really enhance our skills. We are also looking forward to ensuring we offer community-oriented primary health care, looking at our communities wherever they are, and tailoring their care to ensure that they are getting the best. We have a strong team of academic family physicians who really are strongholds of research and innovation. Alongside, we have a lot of family physicians in leadership and management, heading different county leadership, facility leadership, and showcasing how policy governance can be enhanced. And through these trainings, we hope that we can change how policy is implemented within the country and embedding a primary health care lens. So as we engage today, let's take note. Let's change our practices and enhance them with the lessons that will be learned today. We thank Zydus for collaborating with us. We hope that this will now be an annual practice, that we have this masterclass annually, and we continue engaging through the year so that we ensure that we are doing the best within our practices. Thank you very much for choosing to hang out here with us throughout the day, and we hope that we will change your practices and we'll ensure that we impact knowledge. Karibuni. I want to introduce my executive team. I know part of them are here, part of them may be on their way. We are here with our treasurer. Who else is from the executive? Yes. My vice chair will be joining us soon, and the secretary hopefully will be with us. She was out for the Wonka Rural Conference. We have a rural conference that we engage in. We also have our National Governing Council members. Professor Gulnas, please stand up. That's Prof. Gulnas, our one and only professor in East Africa. And she's one of the first ladies in family medicine within the country, trained in South Africa. Yes. And we are very proud of her. We are mama yetu. Thank you. We have various other family physicians in the room. We'll get to know them as we move along. I am a politician, and so I can take the podium for a very long time, and I don't want to do that before I start talking about the Murima and strongholds. So with that said, I would want to welcome our first speaker, who is a clinical assistant professor, Department of Family Medicine, and a consultant family physician at Aga Khan University. Not only that, he safeguards our money at KEFP. He's our treasurer and has been very key in the growth of Kenya Association of Family Physicians. Welcome, Sam Moshero, Dr. Sam Moshero. He has 35 minutes.
Good morning, colleagues. I want to thank Zydus for giving me this opportunity to be a speaker at this important meeting and speak about a very important topic on lipid and lipid management. So as you've heard, my name is Sam Shero. I am a family physician working with the Aga Khan University Hospital. I'm also in the academic side. I am one of the program administrators of our family medicine program, one of the many family medicine programs within our country. And this morning, I'm going to be taking you through lipid management and cholesterol management, which I want to believe as primary care doctors, we encounter this a lot. Thank you. We encounter this a lot in our various practices, and so it's extremely relevant that all of us remind ourselves of some of the things that are important to know about lipid management. So we are going to look at this lipidemia landscape in this part of the world, why it is important to treat this lipidemia, and what we use to treat this lipidemia, and then we are going to be done. Now let me start by showing this systematic review published in 2022 that had over 24 articles with more than 37,000 participants that showed that the pool prevalence of this lipidemia was 52%. Now, some of the factors associated with elevated lipids are the traditional factors that we all know about. That's the BMI, elevated BMI, elevated waist circumference, diabetes, and hypertension. And that was the definition that they gave of this lipidemia. Cholesterol of more than 5, and LDL of more than 3.6, and so forth, and so on. Now, in this cross-sectional survey that was done by a nutritionist from Moi University, they showed almost something similar. That in her sample of 252 households, she was able to show that an LDL cholesterol was elevated in around 45% of the patients, and a lot of patients had less than desirable levels of HDL. In our clinic, in our family medicine clinic within the Aga Khan, we usually do some audits, and this is one of the audits that was done for starting prescription and goal attainment of LDL to date, from January to June. Now, if you look at the first column up there, we basically take a sample of those patients to whom statins are indicated, and that's the denominator. The numerator is those who are actually on statins. And as you can see in our clinic, we are not doing very badly. More than 80% of those who need to be on statins are actually on statins. However, when it comes to those who are reaching goal, that's where the problem is. As you can see, less than 40% of all those patients who were on statins were actually achieving or attaining the goal, the target, which we are going to see what the target is shortly. So you can see in January 34%, and in June it was only 29%. So that tells us that maybe our patients are not taking the medication, or we prescribe, because many times we may prescribe but they do not pick up the medication. So maybe that is the message that is being passed across here. And you can see the numbers are even worse for cardiovascular risk reduction. So that less than 30% of patients have an improved score when we look at the cardiovascular risk reduction. So that is at our main Aga Khan Family Medicine Clinic. I don't work very far from here. There's a clinic we call Peponi Clinic, and we are doing a lot of wellness checks. And from my observation, we have a prevalence of around 55% of just these are patients who are not sick. They've just come to just check their health maintenance visits. So patients, when you tell them that they need to be on medication, they ask you two questions. One, is this medication really necessary? Do I really need this medication? And then number two, they want to know how fast they can get off the medication. So you tell them, okay, we'll use this medication, and then they will tell you, I won't use this medication for 3 months, and that's it. And I think all of us, we have encountered that kind of a thing. And finally, from the Institute of Health Metrics and Evaluation, 2019, you can see that cardiovascular diseases still rank very high on the lists of causes of death in the country. So HIV, AIDS was number 1, cardiovascular disease is number 2. However, this is 2019 data, and I think it may have changed given the advent of proper good HIV medication in our system. So I hope that I managed to convince you that dyslipidemia is an actual problem, and that as primary care physicians, we are extremely well placed to be the ones addressing these problems, because we are not dealing with very sick patients. We are offering primary care to them. So it's important that we know that this is an actual problem that we really need to be cognizant about. Now, why is it important to treat dyslipidemia? Now, there's this large cohort study that took more than 350,000 men and followed them up over time. And it was found that there is a continuous graded relationship between the levels of serum cholesterol and the 6-year age-adjusted coronary heart disease death rate. Yeah, and it is very clear that the lower the cholesterol, the lower the death rate. The higher the cholesterol, the higher the death rate. So this relationship is one continuous. So that means we don't have places where the relationship gets affected. So it's a curved line that is continuous, and one may postulate that it actually goes the higher the cholesterol, maybe the higher the death rate there. Secondly, you can see the slope, it's a graded relationship. So there's a clear relationship. And this study is almost 40 years old. Yeah. So, and after that, we've had many other studies that have shown something similar. There are many, both primary prevention and secondary prevention. And the message is one, and it is clear, that the higher the cholesterol, the higher the mortality. The lower the cholesterol, or the mortality, or the event rate. The lower the cholesterol, the lower the mortality and event rate. And in this case-controlled study called the Interheart study that was done across multiple countries, over 50 of them, again there was something similar. It was shown that actually the lipid, so the lipid, if you had higher lipids, you had much higher odds of getting fast myocardial infarction compared to some of the other factors. Of course, smoking was high in the list. Hypertension, diabetes are the usual suspect. But what I want us to appreciate here is that the attributable risk with high lipids was highest for that risk factor, which is the lipids, compared to the rest. Some of you might be pleased to know that the odds ratio for alcohol was less than 1. Yeah? The odds ratio was less than 1, so I know some of you might be pleased by that. But and then the odds ratio for everything else was more than 1, if you get what I mean. Now, Atherosclerotic cardiovascular disease, the reason why cholesterol is important really is because of this figure that we have always seen when it comes to plaque and plaque formation. So you have the LDL being integrated within the vascular wall, and then gets trapped there by those things called proteoglycans, then gets ingested by the macrophages, and then these macrophages starts producing inflammatory markers, and then you start getting this lipid-rich core with necrotic macrophages, and then you start getting some of the muscles going up there and get a thin fibrous core, and the problem now comes when there's a rupture of this fibrous plaque there that can then lead to other issues. So again, I hope I managed to show you that the lower the cholesterol, the better, okay? And this is not just for people who are sick, this is also for people who are healthy. So you can see those trials, these trials included people who did not have atherosclerotic cardiovascular disease. These were people who are healthy, who are, did not have any secondary issues. And you can see that there is that clear relationship. So again, that's the second main message. Now, how do we treat dyslipidemia? Now, in 2013, the ACC-AHA made it very simple and told us that there are 4 starting groups, and this has sort of been carried on by most of the other big organizations, that is the European Society for Cardiology, and even the Canadians, the British, and so forth and so on. So and this really makes things very simple, that there are 4 people who we want to treat dyslipidemia in. The first group is people with clinical atherosclerotic cardiovascular disease. So anyone who's had a myocardial infarction, a stroke, angina, peripheral artery disease, and so forth and so on, needs to be on a statin. The second group are guys with very high LDL cholesterols. So people with cholesterols of more than 5 or more than 4.9. Again, these are guys who need to be on statins. The third group is the people who have diabetes, either type 1 or type 2, above the age of 40 or 75. And then the fourth group is the guys who have cardiovascular risk. You calculate their cardiovascular risk and you score them, and anyone who has a high risk, then also those are at risks. And we're going to look more in the next few slides. So, clinical atherosclerotic cardiovascular disease include people who have MIs, coronary heart disease, angina, ischemic strokes, TIAs, peripheral vascular diseases, and so forth and so on. So TIA, sometimes these people get forgotten. People come, they have this neurological event, and then we forget to give them statin. So they form part of the clinical, guys who can benefit from statins. So for this group, we want to aim for a high intensity statin, which we will define shortly. We want to aim for a 50% reduction in the LDL-C level, or we want to aim for a LDL-C level of less than 1.8. Now in 2013, when those guidelines came out, there were no hard targets. So they just told us that you aim for 50% reduction of LDL-C. But now, all the guidelines have actual targets, and I think that's good for better guidance. So LDL-C of less than 1.8 for those who are very high risk. Maybe they've had 2 strokes, they've had to be operated twice, and so forth. You even aim for a lower than this, up to even 1.4. And then the use of non-statin agents, we are going to look at that towards the end of the presentation. The second group are the guys who have a cholesterol of more than 4.9. So anyone who has a cholesterol of more than 4.9, you don't need to reassess their risk further. Already, that is enough to inform us that they actually need to be on a statin. Again, we aim for less than 50% reduction. We aim for less than 50% reduction, and we use a high intensity statin also, so maximally tolerated statin therapy. So that would be your atorvastatin or your rosuvastatin, 40-80 and rosuva 20-40, so long as they can maintain it. So I think one of the things we should do better as primary care physicians is to actually make sure that we are treating to target, so that we are getting to less than 1.8, okay? For guys with familial hypercholesterolemia, we want to aim even lower, you can 1.4, because the guys with FH usually have a very high risk of getting some of these atherosclerotic cardiovascular diseases even when they're young. Now let's look at FH shortly. So it's a condition where they have severe hypercholesterolemia, and it's autosomal dominant inheritance patterns. So there can be things that are wrong. There's various genes that could be wrong in FH, but the one that is most common is the LDL receptor gene that has an issue. So in 95% of FH cases, that's where the issue is, but it could be also other genes that have a problem. The heterozygous is much more common than the homozygous, but if you ever have a homozygous FH, you start getting heart attacks at the age of 20. Some of them, most of them will have, unless they are treated well, they will die by the time they are 30, 40 years of age. The guys who have heterozygous FH, they have ASCVD in the 4th and 5th decades of life, and they have a tenfold increase in the risk of coronary heart disease just because of that. Now you can see that statins really reduce the rate of events. You can see the statins really just slow the event rate from that study. Now we diagnose it. There are 2 or 3 diagnostic criteria. There is a Simon Broom, and then there is the Dutch Clinic Network. But basically, anyone with high cholesterol, and then you can see these clinical signs. So xanthomas, you can see the xanthomas there in the tendons, or the lanceolastmas there, and or the corneal arcus. That can, that should raise the index of suspicion for FH. Sorry, how much time did I have, John? Okay. So the next group are guys with type 1 diabetes. So the guys with diabetes, type 1 or type 2, 40 years of age and above, they need to be on medication for cholesterol. So if they have cholesterol between 1.8 and 4.9, you can give them moderate intensity. But if they have a cholesterol above that, or they have other risk-enhancing factors, then you give them high-intensity statins. For patients who are younger than 40, you risk stratify them, and if they fall in the high-risk category, then you need to give them statins. So I don't know how many of us make sure that our patients with diabetes are also on statins. I don't know how many do that. Yeah, that's good. So it's important that among the many drugs we're treating with, then the statins should be one of them. Then finally, it's the group that the last group, they do not have diabetes, they do not have a cholesterol above 4.9, and they do not have ASCVD. So how do you deal with these guys? So you look at the risk modifiers or the risk enhancers, and which factors are these? This include things like family history of cardiovascular disease. So sometimes just taking that extra history really helps. Number 2, obesity, physical inactivity, social deprivation. Can you imagine that social deprivation, psychosocial stress, vital exhaustion, So that, vital exhaustion when you are just stressed, you are type A personality, you don't get sleep, and so forth. Like Dr. Awero here, you just told me you hardly get sleep these days, isn't it? You have a sleep debt of like 10 years. So, we don't want, those are some of the risk modifiers. People with chronic immune-mediated inflammatory disorders, HIV, psychiatric disorders, LVH, CKD, AFib, all these are things that will place the patient in a high-risk category, okay? And these are different for the different guidelines, but they are more or less similar. So guys with LDL of 4.1 to 4.8, they are also in the high risk, guys with metabolic syndrome, CKD, and so forth and so on. And then biomarkers. So we have, for those people who work in places where these biomarkers are available, highly sensitive CRP of more than 2. We have lipoprotein A and ApoB. Okay, so these are things that could some people have access to this. So when you have this, again they enhance your risk. And then I must mention here the coronary artery calcium score, which is is used to again further refine the risk. So it's like a CT scan, and you look at the calcium deposits within the coronary arteries, and then you do a score there. So if any score above 0 is considered to be high. If there are no deposits, then that is considered to be low, and again that is a risk enhancer. Now, after we look at the risk, then we can use various risk prediction models. We have the Framingham risk score, we have the Reynolds, we have the pool cohort, which maybe like if you're like me, that's usually what I use, just because it's easy. It's there there's even an app and so forth. There is the score, which is there for the European populations, and the Q-risk 3, which is there for the British one, the UK, and then WHO ISH risk charts. And I should mention that this is what is in our Kenyan guidelines, the WHO ISH risk charts, and the risk charts look something like this. And so you calculate the risk, and then there's a number there, and depending on the number you get, then you place the patient into one of 3 or 4 categories. There's low risk, there's borderline risk, there's intermediate risk, and then there's high risk. So anyone with intermediate risk and high risk, then you need to think about using statins. Yeah. Anyone with low risk, then you use just lifestyle alone. And then finally, I just want to talk about the agents that are used in cholesterol, treatment. And whenever I'm preparing for any talk about lipid metabolism, and I look at these lipid metabolism pictures, sometimes I can really get a big headache because they are very, very busy and very, very confusing. But just in a nutshell, we have cholesterol that is produced endogenously by the liver, and then we have what we eat exogenously from our food, and there's an interaction between the two. Now, this I just wanted to show where the main cholesterol use medication work. So we have the statins, which work in the pathway that forms cholesterol within the liver. So these are HMG-CoA reductase inhibitors. Those are the statins. And then we have the bempedoic acid, which again is one of the novel acid-lowering medication that is not very long in the Kenyan market. Again, it works on that pathway there. And then we have the ezetimibe, which works on that transporter that that transports cholesterol from the intestines into the liver there. So you'll notice that we don't have fibrates here, which were there maybe 10 years ago. They are no longer there. There is no niacin. Yeah. We have bile acid called sequestrants, but I'm not sure how many of us still use those because there are so many new kids on the block. However, statins, there is overwhelming evidence about them, so these ones have still remained to be a cornerstone of cholesterol medication. So I think this table, we all know it. Atova and Rosuva are the only ones that can give you high intensity statin therapy. The rest either moderate or low intensity. And then we have the ezetimibe. We have the bempedoic acid, okay, or PCSK. PCSK is it's a molecule there that wipes out the LDL receptors. Yeah, so PCSK, when it's produced, it removes the LDL receptor. So the liver is unable to mop out the LDL because the receptors are not there. So when you inhibit it, yeah, then you have a lot of the LDL receptors there. Then the liver can actually mop out many of the LDL cholesterol. So this, in 2023, there was even a big publication that came out that looked at bempedoic acid and cardiovascular outcomes, yeah, in statin intolerant patients, and you can see that there was a clear difference. Yeah, there was actually a lower rate of cardiovascular events with bempedoic acid compared to placebo there, and that was for the 4-point MACE, 3-point MACE, fetal and non-fetal MI, and coronary revascularization. Yeah, and you can see that there was a drop in the LDL cholesterol. So we might actually start seeing a change in the guidelines. As of now, all the guidelines say that statins are the first line. So you use statins, and then if you do not get to go, then you can now use you can use any of the other agents. You can use the ezetimibe, you can use bempedoic acid, or you can use PCSK9 inhibitors. So I think in primary care, because we are not seeing very complex patients, so statins. But I see many of the cardiologists using, many of these. A drug like this one, which is a monoclonal antibody, is bound to be extremely expensive, but it is used for patients who are at very high risk and who are not reaching goal. So niacin, fibrates, these ones, maybe they are not in use much, but I am cognizant of the fact that maybe some of us, this is all we have in our facilities, maybe we can use that. And you can see there are even many other drugs that are coming in. So I think the lipidemia landscape is going to change a lot in the coming years. We might even see statin being displaced as the first line. Maybe, we don't know, we'll wait and see. Great, so as I finish, we'll just look at 4 cases. I have only 3 minutes, but we just have 4 cases and we'll be done. So sorry about this case. I think the question was not included, but basically if you have someone with that kind of a lipid profile, where you have a total cholesterol of 5.2, LDL of 3.6, and so forth and so on, what would you do? Would you recommend lifestyle changes and reassess in 3 months? Would you start rosuvastatin 10, ezetimibe 10? Would you want a highly sensitive CRP, or would you calculate his 10-year risk? Okay, and going back to what we said about the 4 statin benefit groups, and many times we see these kind of strokes. Yeah, they're not very bad. His LDL is somewhere in between there. It's not so bad. It's not very high, but it's also not low. So what do we do? So what we do for this guy is we calculate his 10-year risk using any of the scores that I've shown. And then from there you can decide whether to give him statins or not. If he scores highly, then you give him statins. If it's low risk, then lifestyle, a heart healthy diet, physical activity, weight loss, and so forth. Those are important. The case 2 is about this patient who's 67 years old, who's hypertensive, smokes, admitted with an acute MI, and so forth and so on. So what would we do with this patient? Yeah, would you start a statin, or would you wait for a lipid profile? Again, this is a patient who has already had ASCVD. So this lady needs a highly sensitive, needs a high intensity statin. And if they do not reach goal, and what's the goal for her? The goal for her is less than 1.8, yeah? And you can see after 3 months of compliance to atorvastatin, LDL is still high at 2.7. We want to add a second agent. Now, what agent do we use? The guidelines say you can use either ezetimibe, you can use the PCSK, or you can use bempedoic acid, depending on the costs and what you agree with the patient. Thirdly, we have this 30-year-old male banker who just came for a wellness clinic, and you notice that he had a very high LDL, of 6.8, total cholesterol of 8.9, and so forth and so on. And the father died of a heart attack at 40 years. Actually, this represents like one of my patients. There's one of my patients who I usually see here at Peponi, whose LDL is always above 5. So it's 5, 6, and so forth and so on. And her dad died at the age of 50 with an MI, okay? The unfortunate thing is that for her now, we've tried, she's really drug averse, so we've tried statins. After 3 weeks, she says she's getting muscle pain. Then we've tried this other drug, ezetimibe. We've tried even bempedoic acid, but all of them have just had a problem with her, which, really, well, we are just sort of managing her with lifestyle and so forth. But again, when you look into the literature, there is the nocebo effect. The nocebo effect means sometimes patients anticipate side effects. And when they anticipate side effects, when you give them the medication, then when they get anything small, they attribute it to the medication. And actually, that has been well documented. And I think that patient of mine probably has that. But she clearly needs to be on statins. And then finally we have thank you. Finally, we have this patient who has diabetes. So again, we say that anyone with diabetes needs to be on a statin. So the intensity of the statin is what needs to be checked. As I finish, I've said 4 things. 1, there is a high prevalence of dyslipidemia, probably over 50%, and so we need to be cognizant of that. I've also talked about the statin benefit groups, that is patients with ASCVD, patients with high cholesterol, LDL, patients with diabetes, and patients with high risk when we calculate using the 10-year cardiovascular risk. So thank you. We've not had time to discuss about ApoB, lipoprotein A, and all these other molecules, non-HDL, cholesterol, and so forth and so on, but maybe it's going to come up in the Q&A. Thank you.
Thank you very much, Sam, for that outline. No, don't go away. Please stay. We want to take the Q&A, and we've had a lot. I was busy looking at myself and asking, do I have all the things, the veins, are they thick? You keep asking yourself, and then the 4th and the 5th decade, we are already landed, and we are heading to the 5th. We are all worried. Could we have had, I have family history of dyslipidemia, and I'm asking myself, when did I do my last checkup? So I think I'll book an appointment, but we need questions. What is bagging? A mic will be passed around. You can ask questions, but thank you very much, Sam. It's nice to get these updates. We are always in policy, you're in patient care, and hearing what we are learning now in terms of trying to mitigate the lipid issues is really key. So, who takes the first mic? Dr. Derito? Karibu sana. You've been doing a very good work with the videos.
Morning everyone. I'm Dr. Derito, a family physician in Machakos region. Thank you, Dr. Mosheru, for this extensive discussion on dyslipidemia. I have 2 questions and possibly 1 statement. 1, the question is, the patients we deal with, people with diabetes, hypertension, and many other comorbidities. The issue of polypharmacy. That's where the question of how long am I going to take this drug and the cost effect of all this. That is the first question. Then the second question on the lifestyle modification. What would you say are the critical things that would recommend to patients on lifestyle modification? My comment is that always, as a doctor, it's always good to let the patients own the problem. You, as the caretaker, when you explain to the patient that this is the problem that you have, these are the options that you have, and they see it as their own problems, then they are likely to take responsibility and take the necessary measures to correct it. Thank you very much.
Yeah, thank you, Dr. Derito, for those very excellent questions. In fact, it's true that patients with diabetes might likely have hypertension, and then now there's this lipidemia. They probably have arthritis, so they end up, having so many medications. So, and then of course the issue of the cost, because of these medications, they cost money, and patients need to pay out of pocket and so forth and so on. So I think the principle is, number one, if a patient does not need the medication, then they should not be on that medication. Sometimes it's important, as we review our patients, to always ask ourselves that does this patient really require this medication. Secondly, is about drug combination, fixed dose combination. So, now we even have triple diabetic medication combinations, and I've actually prescribed a lot of this. So when you combine some of the medications, you actually find that from a pill burden of maybe 4 or 5 pills, you may reduce that to 3 or even 2. The issue of costs, obviously there's the issue of costs, but then there's the larger issue of cost effectiveness. When you give them medication, even though they are having to buy this medication, it might prevent them from getting another big complications in the future. I have to agree though that there's no easy solution. Really, you just work with the patient that is ahead of you, and you just work on really on who it is that the case that is standing in front of you there. We're supposed to dance to some music or? Oh, okay. So.
Dr. there is need for a mic here.
No, I think I'll be loud enough.
Thank you and good morning. Now, please comment about these patients who come in and you need a lipid profile. Do you do a start lipid profile, or must they come the following day for fasting?
No, that's a good question. Yeah, so the recommendation now is non-fasting. So they just do a spot lipid profile, non-fasting. However, if you find that the patient has very high triglycerides, above 5, then you can do a starting. Rather, you can do a fasting. Yeah, so if you do, especially if they come right after a meal, and then you find that their TGs are very high, then you might want to tell them, oh, please come the following day. And then the reason is, sometimes the high TG might cause the lipid calculation to be a bit inaccurate. However, for general purposes, random lipid profile suffices. And then I did answer the issue of the lifestyle. Lifestyle is definitely the base. That is what we use for all our patients. So everyone, the healthy patients, the secondary prevention and so forth, they need to be on. They need to be given the lifestyle advice. So that's the diet, the issue of the diet, which again is a lot. If you have access to a nutritionist, usually it's best to work with a nutritionist. Then there's the issue of the physical activity, at least 30 minutes, 5 days a week. There's the issue of weight loss, and so forth and so on. Don't forget, we also have secondary causes of dyslipidemia. So that is also important to check. So your thyroid issues, diabetes itself, metabolic syndrome, certain medications, and so forth. So also those are things that we need to check in our patients.
Thank you very much. At least the sport. Hey, we get tired fasting. Sometimes you fasted, then you arrive at Aga Khan and there's Java. It calls you, senior. Just calls you and tells you just have a cup of tea. And you're waiting at the doctor's plaza and you have got no option. So it's nice to know that we can do a sport. Another question?
Morning, everyone. My name is Dr. Erin Mirza. I'm at the Warwick Center. I do a GP practice. And thank you, Dr. Masheru, for a very informative talk. I'm sure to use the calculator from now on. My concern was Dr. Google, which tells patients statins do this and that to you. So a lot of my clients would visit Google and then come back and tell me that they want to use spirulina, other herbals, natural stuff. For some good reason, I see spirulina does work. However, of course, being an allopathic doctor, you just cannot encourage it to that extent. Another concern I have is to do with grapefruit. There's some people very fond of grapefruits, and I know statins interact. So what options do you go for in those kind of cases? Thank you very much.
Yeah, that's extremely true. That a lot of patients, especially the more informed one, they will be a bit hesitant to use the statins. Yeah, in fact, I had a patient not too long ago who reminded me about, I think there's a lady called Barbara O'Neill or something like that, and then there's also some TikTok videos I've seen on TikTok that talk about statins and the effect on diabetes and the effect on the liver, the effect on even Alzheimer's and whatnot. So we have all these things, and what I've done personally is that I've really just gone back to the evidence and told them that look, the evidence is overwhelming, that statins are safe, and whatever small side effects, including the myopathies and whatnot, pale in comparison to the protection that statins afford to give you. Now, about the grapefruit and about the interaction, I'm actually not very sure. I think that's something that I need to find out. I don't know who else in the audience has had that experience, but maybe something to look at. Yeah. Great. And then I think as we finish, I just wanted to talk about some of the other atherogenic particles, and I just wanted to quickly mention that LDL is just one of many atherogenic particles. And for those of us who work in Aga Khan, our lipid profile is much more comprehensive than what we probably find in other places. So I know in other places it would be total cholesterol, HDL, LDL, and TGs. But here we will have the non-HDL cholesterol, yeah, and we also have access to the ApoB. In fact, ApoB, which is a particle in one of the lipid shells, the lipoprotein shells, is a very good marker of the total burden of atherogenic particles. Obviously, it's extremely expensive. Then lipoprotein A is one of the other markers that can be used, particularly in patients who have had early onset premature, relatively premature cardiovascular death. So that is also another thing that
to check for atherogenesis. Yeah? So LDL is just one, yeah? Probably the most important one, but it does not tell us about the total burden of atherogenic particles. So when you have a cholesterol panel that can give you non-HDL cholesterol, that even becomes much better. So I think that's good.
Dr. I wanted to ask about your data at Aga Khan. I was very much impressed that you're actually gathering the data from all the patients that you have. And I was quite scared that 55% of wellness checks actually had dyslipidemia. I wanted to know, in terms of your current personal clinic data, do we have a correlation which actually looks the same? Do we have a similar pattern in our patients within the clinic where you're talking about the risks for cardiovascular events being directly correlated? Have you had any correlation with your own data as well? And secondly, in terms of side effects, when now bempedoic acid is being brought into our market, is it really as good as it claims to be in terms of a reduction in side effects compared to HMG-CoA inhibitors?
Okay, yeah, so actually there is one of our residents who's going to look at that data and going to probably do it as part of our master's dissertation. And basically what we are doing is we are looking at...
So what we are doing is that we are looking at the LDL cholesterols, the lipid panels, and then we are doing cardiovascular risk scoring, and we are trying to associate the two. So I think that question is going to be better answered when we have that project complete by one of our residents. We are just in the planning stages, but we hope it's going to give us some information. And then I don't have much experience, unfortunately, with bempedoic acid, but from what I've seen in literature, it does claim that for our
statin intolerant patients, that bempedoic acid would actually be a good alternative, and it actually has good cardiovascular outcomes. Yeah. So maybe many of you probably have more experience than I do on bempedoic acid, but it could be one of the things. Like now, our patient, but I think that patient of mine who is clearly indicated, she clearly needs to be on statins, has not tolerated anything, even though we think there are other things probably going on, the nocebo effect and all, but it's probably better than patients who have statin intolerance. And I think the rate of statin intolerance is extremely low. The true statin intolerance that is objectively identified, I think the rate is extremely slow. Low. Yeah. Great. I think we are done. Yeah.
Thank you very much. Thank you very much, Sam. Unfortunately, Kenya Power decided to annul the lines, and I'm wondering, is it raining? Because that's when they remove the lines so that they don't get wet. But we will continue, isn't it? So we've heard from Dr. Mushero about lipid management. Our next speaker will be talking about something very key, about the nose and the skin. And what the nose knows, the skin speaks. And remember, Dr. Mushero has talked about something very key, atherosclerosis. Does the nose have any relation to even atherosclerosis? You know what, we had a discussion out there about pollution. It can play a key role in terms of hardening your blood vessels. And now when the plates come in, they find a safe place to lounge. So when you look at all these speakers who are coming in, they have a correlation. And we want to welcome Dr. Angela Wairimu. Dr. Angela Wairimu is a consultant head and neck surgeon at Narok County Referral Hospital, affiliate to Progeny ENT Clinic in Nairobi. Amesafiri kutoka mbali, imagine, from Masai Mara, the county where we have the most lovely park. Welcome, Angela.
Good morning. Thank you, Dr. Mugambi, for that introduction. I am from Narok County, which is a few hundred kilometers from here. I'm also an affiliate at Prodigy ENT Clinic, which is in Upper Hill, KNA Center, third floor. I just wanted to get a feel of who is in the audience today. So just by show of hands, how many physicians do we have today? Physicians? Okay, perfect. How many general practitioners do we have in the house? General practitioners? Perfect, all right. Any other clinical field I have left out? Who? Family physicians. Okay, family physicians. All right, great. Okay, so today we'll speak on allergic rhinitis and urticaria. We had a conversation today, as Dr. Mugambi said, and kind of looking at things from a primary healthcare perspective. It's interesting to note that we tend to focus a lot on the secondary prevention of these conditions, but what goes a long way and what is being practiced even in the developed world is the primary healthcare prevention. So looking at the environmental implications of some of these conditions, allergens, pollutants that are in the air, and how they impact these conditions that we see day to day. I know that this is something quite common and that a lot of us interact with when we see our patients. And again, just that show of hands, I really like asking questions. How many of us interact with patients that come with these conditions, or what we think is allergic rhinitis? Yeah, over 90% of us. So it is very impactful. So my scope today will look at basically an introduction, an overview of these conditions. We'll look at both allergic rhinitis and urticaria, pathophysiology, diagnosis and management, some of the complications, and a conclusion. So, as I said, these are common conditions that we encounter in our practice. At least 1 in 6 patients or 1 in 6 people in this room have suffered allergic rhinitis. So it is that common. The significance of these conditions is increased impairment of quality of life, healthcare costs that are increased because the management or the drugs that we use for this are quite expensive. And we see that allergic rhinitis is a component of a systemic allergic response and usually associated with other conditions such as asthma, atopic dermatitis, and other conditions. So for us who also treat asthma, you find that our patients come with a host of other conditions, something we call the unified airway disease. So the patient will have allergic rhinitis, will come as well with features of asthma and eczema. So a study done by a gentleman called SMI in 2001, he looked at the prevalence of allergic rhinitis, asthma, and eczema in Uasin Gishu County at a hospital there. And he was doing a cross-sectional comparative study, and he found that in a span of 6 years, there was an increase in the prevalence of these conditions. That goes to say that with increasing time, we're seeing more and more patients with these conditions. So definition, Allergic rhinitis is inflammation of the nasal passages due to allergen exposure. We also have an IgE-mediated immune response that is seen in the early phase, and a leukotriene-mediated response seen in the late phase of allergic rhinitis. We also have a non-IgE-mediated response that I'll allude to a bit later. So allergic rhinitis can be seasonal, can be perennial. So for the seasonal allergic rhinitis, we also know it as hay fever, and it's caused by seasonal allergens like pollen. Some of the causes of allergic rhinitis include airborne allergens such as pollen, dust mites, mold spores, and animal dander. We previously were discussing about a study done by a consortium where they have put air monitors in different places in the country. And interestingly, one of the things that came up was in a suburban area in the evenings, a lot of the elite would like to have a chimney burning, a fireplace with wood. And what happened, one of the air monitors at night, when you expect the air to be cleaner, there are less cars on the road, it was consistently active. It was red. And when they looked into it, they found that every household had a fireplace or a chimney active at the time. And so that contributed to the reduced quality of the air. So a lot of the things that we do subconsciously contribute to allergic rhinitis. And the other thing is in our urban setups, we have a lot of apartments coming up. We are looking at complexes of maybe 8-9 floors. The rooms are closed, the windows are closed throughout the day. So what happens, and there's a lot of water activity, showers, hot showers, so mold begins to form within the walls. And then you find children coming in, being brought by their parents because they're consistently having nasal congestion, they're always having running noses, and those are the questions that are being asked, like why are my children always having this CBD, having colds all the time? And these are some of the things that we need to think about in a broader perspective on a primary healthcare level, and even passing on that education to our patients, that the environment that we're living in contributes greatly to these conditions that we have. A bit of the pathophysiology. So in a pre-sensitized individual, so an individual has had exposure to some of these allergens, the pollen, dust mites, and the animal dander. So we have IgE-specific antibodies to these allergens. So the allergens bind to these IgE-specific antibodies, resulting in the host mast cell degranulation and release of histamine in the early phase. So when the histamine is released and binds to the histamine receptors on the target cell, then what happens is there is stimulation of the trigeminal nerve. So you find the patient comes with bouts of sneezing. There's also stimulation or induction of the mucus glands. So there's lots of mucus coming from the nostril. The patient comes with clear rhinorrhea. So then for about 4 to 6 hours later, we have the late phase. And in the late phase, we have recruitment of a number of cells, increased permeability of the blood vessels in the nasal mucosa. And so we have recruitment of the basophils, eosinophils, the T helper 2 lymphocytes, releasing cytokines that also release interleukin 4, 13, among others. And what happens is nasal edema as a result, and the patient comes with nasal congestion, which is a hallmark of allergic rhinitis. So the types of allergic rhinitis, we talked about the seasonal. These include the seasonal triggers. The triggers include pollen, dust in our setup, where we have seasons where we have lots of dust and sun. January, we see a lot of patients coming in with allergic rhinitis. Perennial, which occurs year-round. So if you're in a house with mold, then January to December, we're going to have those issues. Animal data as well. Occupational as well has been put as a type. And this is where we have workplace allergens like chemicals and dust. And the take-home for this is history taking being very crucial, because we're looking at allergen avoidance at the end of the day. So it's important to get that feedback from our patients, and this helps us categorize what could be going on with our patients. So the impact or the quality of life, these symptoms of allergic rhinitis that we look at significantly affect sleep, productivity, and daily activities. There's a study done by Michel et al., and he was looking at patients with allergic rhinitis and their sleep quality. And he found that over 80% of patients with this condition have impaired sleep quality. So the patients will come in very fatigued, tired, and that has a very big impact on their productivity throughout the day, associated with other conditions such as asthma, sinusitis, otitis media, eustachian tube dysfunction. So it is a condition that needs to be really addressed in due time. Some of the symptoms I've talked about: sneezing, bouts of sneezing, especially in the mornings and evenings, clear rhinorrhea, itching of the nose, eyes, and throat. We have nasal congestion that is seen in the late phase, fatigue, and postnasal drip. So for the physical examination, just a few. This is a normal nasal cavity, and this is an abnormal nasal cavity. So the nasal septum, which is seen on the double asterisk, and then we have the nasal septum on the right side, and then we have the inferior turbinate that is looking pink-red, very normal, the size is normal, and then we have the middle turbinate up there. So in a patient with allergic rhinitis, you find that the inferior turbinate and the nasal mucosa, it looks pale and boggy. And then you can also find features of nasal polyposis, which is alluded to with the broken arrow. There was a local study done by a gentleman called Gadiru et al. He looked at the prevalence of allergic rhinitis among KMTC students, and what he found was there was a point prevalence of 13%, and out of these patients, 81% of them had their daily lives being affected. Most common symptom was sneezing at 83%, and the most common physical finding was the hypertrophied inferior turbinate, which we have seen right here. So for the physical examination, other than what we've pointed out, another common finding is this transverse crease, which is called the Darier's line, and it is as a result of, because of the itching. So the patients tend to rub their noses and they kind of tend to do this action that's called the allergic salute. And they also tend to have the allergic shyness or the hyperpigmentation below the eyes. So diagnosis, detailed history, a thorough physical examination. Those two are key, or they're really enough to make a diagnosis of allergic rhinitis. We also have skin prick testing or allergen testing. This is done when patients are unresponsive to empiric treatment. And the reason for this, it is invasive and it is also very expensive and time consuming. So for patients who are not responding to treatment, then we can put them through the allergen skin testing. Nasal endoscopy as well, if we're suspecting other conditions associated, for instance, the nasal liposis, chronic rhinitis. For management, I think I should have added something else. Should have started with the primary healthcare. Allergen avoidance. It is a bit tricky, especially if a patient is allergic to dust. You cannot control where they are going and where they're getting the dust from. But in terms of different conditions, we have animal dander, the patients that have pets in their houses, and some really have an emotional or attachment to their pets. So for such patients, we advise them that they can confine the pets in one room and try and keep them there, so that if there's a patient or there's somebody in the household who has allergic rhinitis, they're not in contact with their pet. So the other thing is pharmacotherapy. We look at intranasal corticosteroids, antihistamines, leukotriene receptor antagonists, nasal decongestants, and immunotherapy. So intranasal corticosteroids are the first line of treatment. This is just an illustration of what the patient would present with. And this is where the skin is speaking as an atopic manifestation. And urticaria is also called hives. It's a common skin condition characterized by appearance of raised red itchy wells of the skin. Occurs in about 15 to 25% of the population, common in both adults and children, and associated with angioedema. So classification, we have acute urticaria, which is less than 6 weeks, triggered by food like eggs, shellfish, dairy products, infections, bacterial, viral, parasitic infections as well, or medication, such as the beta-lactam antibiotics. 50% of the causes of urticaria are unknown. So you find a patient who comes in who has had no trigger or does not have an idea of what could have caused this urticaria. Chronic is more than 6 weeks. The prevalence is 0.5 to 5%, seen more in females more than males. Some of the causes have been attributed to autoimmune disease, viral and helminthic infections. So here we have the IgG antibodies binding onto the IgE on mast cells and basophils, and results in a release of histamine and inflammatory mediators. The third type is the inducible urticaria or physical urticaria, triggered by a physical stimulus. And the most common manifestation is what we call skin writing. We have patients who will scratch the skin and you'll see the marks on the skin. Other triggers or causes include pressure, cold, heat, water, vibration, pieces of clothing that affect the patient's skin, usually resolve within 2 hours. The pathophysiology, very similar to what we looked at with allergic rhinitis, where histamine is a primary mediator and it comes from the muscle degranulating, and release of the inflammatory mediators like leukotrienes and prostaglandins, resulting in vasodilation, increased permeability of vessels, and recruitment of the mast cells. The activation of the mast cells can be both immunological and non-immunological. So immunological activation is mediated by effectors of adaptive immunity. So in the acute phase of urticaria, you'll find that these are basically the type 1 hypersensitivity reactions where there's cross-linking of the IgE with the mast cells. And in the chronic, we are looking at the type 2 to 4 hypersensitivity reactions. So we have the IgG complexes and the T helper cells being recruited to or stimulating this chronic urticaria. There's also non-immunological activation where drug molecules or food molecules can bind themselves and result in this cascade of events. Clinical presentation, history, physical examination are very key. And basically, in the physical examination, we have pink-red papules and plaques with areas of central pallor. So the patients come with the wheals less than 24 hours. And what's important to note is after the process, there is absolutely no way to tell that this patient had urticaria. So there's no skin changes, hypopigmentation. So you find a patient can come after the fact and tell you that they're experiencing this. So something we advise the patient is maybe circle. When you're having the flare-up, you can circle the areas that this is happening. And then if you're not able to get to the clinic in time, then we can have a discussion around that. And about 40% of patients with urticaria, they also suffer from angioedema, which is a whole other topic on its own. Hopefully next time we'll get more time. So for evaluation, we have specific and non-specific testing. What is common or available in our clinics, the full blood count, CRP, ESR, which look at the inflammatory markers, thyroid antibodies, which are seen in chronic urticaria as well. For the specific tests, we talked about the skin prick testing, serum-specific IgE testing, among others. And this is possibly done in patients who have been unresponsive. So management, basically, other than the allergen avoidance, we look at the pharmacotherapy. First line is a second generation antihistamine, usually is the mainstay of treatment. If the control is inadequate, after 2 or 4 weeks, we move to the second line, where we are increasing the dose of the second generation up to 4 times. If control is still inadequate, we move on to adding a third line where we look at the monoclonal antibodies, for example, the omalizumab. And within 6 months, if the control is still inadequate, we look at moving to adding cyclosporine to the management. This is just a repetition of what I've talked about. So the strict allergen avoidance, antihistamines, and the corticosteroids. So our take-home for today is that we want to look at it from a primary healthcare perspective, really educating our patients on what we should do in our environmental capacity. If we have homes, trying to plant as many trees as possible, then this kind of forms a barrier around your external environment and reduces your chances of interacting with these allergens. Strict allergen avoidance, and also now this is sort of just to emphasize on some of the management that we can implement in our patients. And I know I have seen one of the drugs, I think Odimont LC, that can also be used to manage or control symptoms in our patients. These are my references. Thank you.
Thank you very much, Angela. We'll ask you to grab a seat, have some water as we go through the questions and answer session. We'll take like 5 minutes so that we get to hear from Angela and get to know more in terms of the questions that you have to raise. Angela, I had a question. I put down on my small Q&A session. You said something about the nasal spray and the direction. When you're given that nasal spray, you want it to go into the problem, isn't it? So you put it deep in. But you've told us something different, and today I'm learning. So demonstrate for us.
Okay, sure. So as I said, so the nasal, the tip of the device should, yes, go into the nasal cavity, but it should be directed to the ipsilateral eye. And what that does, first of all, it avoids the nasal septum. And because of the sensitivity of the septum, we have lots of blood vessels, and we also have cartilage. So there's a lot of irritation on the patients, and you find the patient will come back and say, that doesn't work for me, or I even feel worse after using it, and that is the reason. So we direct it towards the inferior turbinate laterally, and this increases absorption of the drug molecule and prevents that irritation to the patient.
Kenya Power has enhanced the lights again. So questions, and thank you very much for that highlight.
There's a question there.
Yes. There you go.
Yeah, thanks, Dr. Angela. I think one of my learning points is that the technique of the use of the nasal, and I think since now we have here, we also have drug representatives. When you have these devices, it's always good to teach our doctors how to use it, because if the patients don't know, then inakuwa kundi kabisa. So thank you very much. Then my question is, Dr. How do you deal with this allergic nasal polyposis?
So it is actually a very the intranasal corticosteroids, let me say, is our friend as ENTs, because that one drug, it can deal with like 4 conditions concurrently. So for nasal polyposis, we recommend 4 to 6 weeks of intranasal corticosteroids, and we then assess the patient afterwards. If the features of the nasal polyposis are still there, then we convert it to surgical management. Same applies, chronic rhinosinusitis is the same. That is still the treatment modality that we use. Yeah.
I had a small question. For people who are elderly and have allergic rhinitis, some of them complain of extreme dryness if you exceed a week's period of nasal spray. What are the guidelines on elderly people?
Thank you. I think because of
Because of the geriatric population, we find that their mucosa generally is thinner, and it is more prone to getting affected by this intranasal corticosteroid. So what we advise or what we give in a clinic setup, usually add on something like liquid paraffin drops, and that tends to help moisten the nasal mucosa. So an interval of about 15 minutes between. So
start with the intranasal corticosteroids, and then 15 minutes later they put in the liquid paraffin drops, about 2 per nostril, twice a day usually. Really goes a long way.
Sorry. Is there any time that
there used to be a story about helmets. So is there any correlation with all these symptoms with the systemic problem, gut problems?
Absolutely. So in the pathophysiology, we looked at one of the immune responses is eosinophil activation or recruitment. And we know that in helminthic infections, the eosinophil count really goes high. So if a child has infestation, but helminthic infestation, then there could be a propensity to to form the allergic rhinitis. And as earlier we alluded to, being a multidisciplinary approach, looking at the patient holistically and what other symptoms, because I would say that the symptoms will guide the management. If the child comes with allergic rhinitis, then I would be inclined to treat the allergic rhinitis. But if they have other telltale signs of parasitic infection, then definitely treat the patient as a whole.
Hello. I would like you to clarify about the use of the intranasal steroids in pediatrics, because most sources I come across say the efficacy has not been established for children less than 4 years.
Okay, thank you for that. So we actually have had that back and forth, especially I think in the last 6 years, where there was a cutoff for children less than 4 to 6 years being given the intranasal corticosteroids. Now they looked at betamethasone as a molecule, and that has been found to be safe in children less than 4 years of age. So you find that when patients come to the clinic, we would put them on Probeta drops, which reduces, and more commonly allergic rhinitis as well in children occurs with adenoid hypertrophy. So we put the child on the betamethasone, and because it has a local effect, it doesn't have a systemic propensity. Yeah.
Hey Doc.
Hi.
A nice presentation. Now, I have 2 questions. One, I have patients who are maybe having this rhinitis, and since COVID came and there was the use of masks, so most of them have maintained the use of masks. So I don't know if it's going to affect their lungs or no. Maybe you have to make a comment. Then secondly, I've noted that some patients who have hypertension and they are using ARBs, SE inhibitors, later on after they have used these drugs for some time, they develop rhinitis. I don't know if there is a relationship. I know they do affect the prostaglandins. I don't know if you have any experience on that. Some of them decide to stop because of that. Thank you. Especially losartan, telmisartan, and what have you. Thank you.
Okay. The first question, if I get you right, alluded to the effect of masks and the impact it has had on allergic rhinitis. Yes, clarify?
They use the masks to prevent exposure to these allergens. So some of them come and ask us, do they continue using the masks? Because I think when they're putting on the masks, the effect is a bit minimal. So my question is, as an ENT surgeon, what is your take? Do they continue using the masks for long periods, or it will harm their breathing system or whatever?
Okay. I will say that after COVID came and went, we had our follow-up patients with allergic rhinitis really reduce, because they were definitely less exposed to the allergens. in terms of if they should stop using the masks or not, maybe I look at it from an aspect of quality of life. Prolonged use of the masks, I think, also has a social impact. We are humans, we need to communicate, smile at each other, speak freely. So I would not say that would be a treatment modality for patients with allergic rhinitis, but it definitely goes a long way for patients. Patients have really said that using the masks has helped them get over this allergic rhinitis. The second question was on the ACE inhibitors and some of these antihypertensives. So we would classify that as drug-induced rhinitis, and the mainstay of treatment usually is changing the medication or modifying the medication, I think, because for as long as they are using the medication, putting them on an intranasal corticosteroid is a bit counterintuitive, in my opinion. Yeah.
So I want us to end up there, that we grab a cup of tea and we raise our blood sugar. Parting shot?
Parting shot is educate your patients. Educate them on what can be done to reduce these conditions, these atopic manifestations of the conditions that we see. Thank you very much.
Thank you very much. And let's give our clap as we welcome Walter to give us the way forward.
I want us to stand for a minute. Just stand wherever you are. Just stand. Kelly, give me something there, Kelly. No, you're told, Dr. Sam told us. I want us to do some. Just follow that. Yeah. Take it in, yeah. Let's enjoy it. Give me some beats. Oh yeah. Let's stretch. Get some space. Oh yeah. I can't see you. Put some energy, some energy. Some energy. 30 seconds. Stretch. Yeah. Energy. Yes. Yeah, we are breaking some calories. Yeah. Okay. Round of applause. That was a good one. I want to quickly introduce to bring Dr. Joy, who will introduce our speaker, and then we shall continue. Yeah, Dr. Joy, please have the honor of introducing our speaker.
Thank you very much. I want to hand over this session to our session chair, Aisha Mwatano. She is from Nyandarua County and a family physician. She will take us through the next session and introduce the speakers.
Thank you so much, Dr. Joy. I'm not sure after the upper arm exercise I'll be able to hold this microphone, yeah? All right, so as she said, I'm Dr. Aisha Mwatuano. I would like to welcome you all after our sumptuous tea break. And our next session, we will have a pneumologist and critical care physician, none other than Dr. Peter Munyu. Karibu sana.
Thank you, Aisha. Tumefika afternoon ama bado morning? Yeah, that's nice. And I'm very happy to have been invited by Zydus and the Kenya Association of Family Physicians. we talk about things that are close to my heart. You know, the lungs and the heart are very close. We look at atopy and lung function, and when I read about this, I thought I would talk about two things. One is asthma, which has a lot to do with atopy, and a short mention about COPD, which has less to do with atopy, but these two conditions are closely related, but very different. So I'll just make a small comment about that. So as a way of introduction, we talk about atopy. And what is atopy? Daktari, you did a good job because now mine is easy. But really, atopy is a predisposition to an immunologic response. And the way I describe it to patients is that this person who has allergy or atopy tends to react excessively to things which other people's immune systems ignore. For instance, many people work in quarries, very dusty, but they never sneeze much. But this person who has got atopy triggered by dust, they'll go into a room and even before they look around, they start coughing, their eyes are tearing, they are sneezing, all those things. And this is because the body's immune system is producing certain chemicals, and these chemicals are inflammatory and causes the response that we see. We do know that atopy has a lot to do with genetics, although we do know also that some people who have no familial genetic or familial, like now they don't have a relative with atopy, can develop atopy. So it is not always a must that if I have asthma, there must be people in the family who have asthma. And the same applies to allergic conditions and atopy. There are people who develop it de novo. So even as we talk about genetics, which play a big role, let us remember not everyone has a genetic predisposition to this. Indeed, some twins have been found, not one has atopic condition and another one has no atopic condition. But the more common thing is that the two twins will look similar. And there are certain chromosomes which have been found to be important in this issue. Now, why are we wasting time talking about atopy, asthma, and so on? And that leads us to the epidemiology, where I will say about 80% of people who have atopy and atopic diseases, you'll find that most of them will have a familial history. And we can see that even in monozygotic twins, as I was alluding to before, there is a 50% concordance. Why is this important? It is important because many times a patient you come, you clearly diagnose an atopic condition or asthma, and they will tell you, lakini kwetu hakuna, and it will be a to and fro kind of thing. Having talked about atopy, let's now dive into asthma. And we do know that asthma, by definition, is a heterogeneous condition. And what do we mean by heterogeneous condition? It means that this disease manifests differently amongst people. What that means is that Daktari here will be coughing, Daktari there will be having chest congestion, Daktari there will be having chest tightness, and he will be having all these symptoms varying in intensity. The other aspect of heterogeneity is in the person. And this is very important in family physicians because you see from the preborn babies, many of you are doing ultrasounds in pregnancy, up to the time a person is 90 years. And a history you frequently get in adults is that I've never had asthma. But when you dig deeper, you realize this was a fellow when he was 6 years old, 7 years old, whenever he would run, he would get short of breath, more than usual. Or he had asthma and the mother was told he will outgrow it. You've heard that story. And then, because it was not emphasized to them that they had asthma as a child, and maybe the asthma as a child was wheezing, and now he has presented at age 49 coughing. No wheeze at all, but the fellow is coughing incessantly whenever he goes into a dusty room. Unless you think about it, you may not connect this to the asthma they had as a child. So very, very important to remember this issue of heterogeneity in the patient and amongst people. Because many people will tell you, I'm not asthmatic because I don't wheeze. Why do people develop asthma? It's because their airways have hyperresponsiveness. They are reacting easier and more severely to certain either external or internal stimuli more than the kawaida person. External stimuli are easy. It's dust, smoke, pollen, paint, polish, all those things, perfume. But internally, let's not forget that some people will have things like Daktari talked about allergic rhinitis, sinusitis, women when they're in their periods, you've heard of catamenial asthma, stress. I stress Daktari, and tomorrow she comes to the other Daktari busy, or my husband, or not my husband, my wife stresses. Yeah, now it's become very difficult these days to know it. But mimi si wa mlengo huo. So a person is stressed by the spouse, by the son who has refused to go to school, and they start having the asthma symptoms. So let's look at internal as well as external stressors that may lead to asthma attacks. Asthma is major, and if you look at the data, you'll find that in 2019, there were about 2,000, no, this 2020, this is the latest data we could have. We had 2,300 people who died in this country because of asthma. The tragedy is that all these deaths, at least majority of them, maybe 99.9%, are preventable. So why are we having so many deaths? People are not getting proper diagnosis. They are all on the blue inhaler. You know that one? Yeah, all of them are on a form or another of salbutamol inhalers forever, and they're using canisters upon canisters. So very, very important we keep an eye on these patients, because these deaths primarily affect the very young people and they are preventable. The etiology of asthma, we all know, it starts with an allergen which gets into the body and it triggers an inflammatory response. This word inflammation, you hear it time and time again when we talk about asthma. And it is important to emphasize it, because when you are managing asthma, we must deal with inflammation. Otherwise, our patients, you get half treated. And that cascade shows that the allergen is taken up by the antigen presenting cells, that's your macrophage. There's involvement of the mast cells, eosinophils, and so on. So even when we are treating our patients, for example, we decide to give our patient montelukast, we are only dealing with leukotrienes. We are not dealing with eosinophils, we are not dealing with neutrophils, we are not. So as we treat asthma, let's have this in mind that this is an inflammatory condition. The next picture, I wish to be clearer, because it shows you just how complex this system is and how many cells are involved in the development of asthma and how many chemicals are involved. At this point in our knowledge of asthma, the drug that works best to deal with all this inflammation is a steroid. But you all fear steroids, especially if they are systemic. Therefore, we push more and more. Indeed, all patients with asthma should have an inhaled corticosteroid as the backbone of their asthma management. Dr. ENT had talked about sinuses, rhinitis, polyposis, and so on. And I want to push it a step further and talk about the unified airway hypothesis. The airway starts from the tip of the nose up to the alveolus. But remember, there are other structures around there like sinuses, the ear connected through the middle ear to the nose, the intestinal system starting at the esophagus, the stomach is just next. Remember, all these things are controlled by the vagus nerve, and therefore a problem in the stomach may end up causing triggering asthma if this person has got asthma. So as we take our history, let's ask about skin also, because eczema, she talk about sinuses, ear inflammation, so that even as we treat this patient with what you have said is the backbone, that is the inhaled corticosteroid, we are also looking at, does this patient have rhinitis? Yes. Give a nasal spray, a steroid nasal spray. Does he have a stomach problem? Is he having reflux? Give him something to sort that out. If you look at all those comorbidities, then your asthma control will be much better than if you just gave them a steroid inhaler. When we are diagnosing asthma, I usually say 80% of asthmatics will be diagnosed on history. If you take a good history, it will diagnose your asthma. And you don't even need to do tests. The tests are important, but by the time you are saying this patient is going to get a spirometry or a FeNO test, you have already clinched a diagnosis or a very, very probable diagnosis. And you suspect asthma if they are getting intermittent symptoms. So there are times when this patient will be completely okay, then at other times the problem occurs. And they may be okay for a week, a month, 10 years, 30 years. Maybe this fellow had childhood asthma, now they are 50, and they come back with wheezing. That is the nature of asthma. And it's important to educate our patients, that is the nature of asthma. Because sometimes you treat them very well, after 3 months they are okay. After 1 year, because they disappeared, after 1 year they keep walking from hospital to clinic to wherever, because the symptoms have come back, but they didn't know they would come back. So they are thinking it's a new condition. If a patient has coughing, it may come with wheezing, it may come with chest tightness, difficulty in breathing, and pain. Some patients will only have pain, chest pain. Remember, there are different descriptions of pain. When some people feel tightness, they think it's pain or they feel it's pain. If it's heaviness, they feel it's pain. Ask for these things. If they have one or more of these symptoms, suspect asthma. But also, dig a little deeper. Is this cough only there on and off? Or is it there and it's getting worse? Those small distinctions will help you decide, this is asthma? No, this sounds more like TB. This sounds like more like pneumonia. And so history is very, very important. After you've taken your history, I'm sorry this may not project very well because you are far and I can hardly see it myself. So once we have decided that this patient's symptoms fit the asthma symptomatology, we have to ask ourselves, what is the next step? The next step would be ideally to do a spirometry test. Once you do a spirometry test, you either confirm asthma or not confirm asthma. If you do not confirm asthma, but you're very, very suspicious, there's another test now available in a few centers called the fraction of exhaled nitric oxide, FeNO test. So you can send your patient for the FeNO test. If the FeNO test is supportive of the diagnosis of asthma, then you're happy, you treat that patient. Sometimes you are so convinced that it is asthma that you are allowed to give empiric therapy for a few weeks and see if the patient gets better. Some people work in places where there is no spirometry available. You can also use a peak flow meter to assess for reversibility. So you give the patient a peak flow meter, they go home, they record morning and evening peak flows, whether they are children or adults, this can still be used. And then they come after maybe a week or two and you assess, is there adequate difference between morning and evening? And if there is, then you have confirmed your diagnosis of asthma. Sometimes your patient comes when they are very sick. They are wheezing a lot, they can't sleep. In that patient, you are still allowed to give empiric therapy. What I would say is there are certain mimics of asthma. Not everything that wheezes is asthma. And remember the opposite, that not all asthma wheezes. So if a patient has come with cough, it's also common for us to get pneumonia, to get TB, heart failure. Please look for signs and symptoms of those things. And if you get them, please follow that pattern, elucidate whether it's the reason. But if you are clear this is asthma, you've done your x-ray, if you are suspicious of pneumonia, it's negative, TB is negative, you are allowed to give empiric therapy. Then we talk about asthma treatment, and how we are looking at asthma is we place patients on certain steps depending on their symptom characteristics. If the symptoms are very rare, like they are coughing once a month or they are wheezing once a month, a day or two, that's a patient you can give intermittent treatment because they fall in stage group 1 and 2, step 1 and 2. And the current guidelines are that we don't give patients only a bronchodilator like salbutamol or ipratropium. We are going to start with an inhaled corticosteroid You may use bronchodilators if your patient has chest tightness or wheezing, but whenever you use a bronchodilator, please give inhaled corticosteroid because we know these patients' problems are due to inflammation. So no room nowadays of just giving a patient a blue inhaler or just salbutamol inhaler. And it is good, this gentleman here have brought us, is it Fortide, which you can use for PRN uses. Now, if your patient has symptoms more than that, 2 to 3 days a month, that's a patient you want to put on regular therapy. This is a patient you talk to, you convince them to use their inhaler every day in the morning and in the evening. There is something we call MAT therapy. This is where you tell your patient your dose is morning and evening. However, if you are having symptoms at any other time, you can use this formoterol containing inhaler to sort out those exacerbations. So your patient, you have the same inhaler, that's formoterol ICS inhaler for regular use or maintenance therapy. But if they get an exacerbation, they can use the same inhaler for aborting those attacks. Why is this important? Many times you give a patient budesonide inhaler separately from salbutamol. Two things. Number one, salbutamol appears to give immediate relief. So many times they'll forget even about the inhaled corticosteroid. Number two, salbutamol in this country is so cheap, it's like a few hundred shillings compared to the budesonide containing inhalers, which cost maybe 1,000, 2,000, sometimes even 4,000. So if I am to choose between taking my child to school and buying an inhaler, which one do you think I'll choose? So it is important for us to get good compliance. Give this patient a combined inhaled corticosteroid with formoterol so that they use it even for PRN. Why? Inflammation, inflammation, inflammation. Then there are those patients who are very difficult to manage, where you increase your daily doses of inhaled corticosteroids, and in the patients who are not responding to moderate doses of inhaled corticosteroid and formoterol or inhaled corticosteroid salmeterol, please send those patients to us so that we can try all those other things, omalizumab, we do skin testing, we do other things which will help us tell why is this patient not improving. Something else. This is what I will call the asthma management cycle. And it has 3 steps. When the patient comes, assess. And when you assess, you are confirming the diagnosis. Maybe this patient has been told they have asthma, but indeed they have TB or they have heart failure. The other thing is you ask them about their symptom control. If you get out your phones now, 1, 2, get your phones out, get your phones out, mobile phone, go on to Google, look for asthma control test. This is a self-administered test you can give to your patient. You tell them, is your asthma well controlled? Yes, tuone, unampatia. Anajaza hiyo asthma controlled test, and it's just ticking what they want, and you'll find that many of them are well controlled, you're happy. Some of them have misunderstood or misperceived their symptoms, and you'll find they have very poorly controlled asthma, but they had convinced themselves that they have mild asthma. Do we do allergy testing in asthma? Dr. also talked about skin testing. We also don't do it so much, especially in adults. It doesn't add value in majority of the patients. Why? Many of my patients, you tell me I react to dust, I react to polish. Then, let's say we find that they are allergic to certain grass. Mtafanyia hiyo grass nini? Ama they are allergic to dust. What will we do? So let's just manage them. But there's a small group of people where they have very difficult to control asthma, and when you do this test, you do an environmental screening, you find that indeed there are certain things in the environment which you can talk about. I'll present a short case. This is a 47-year-old presented with 5 weeks history of cough. If you hear that, please think about TB. But also, she had chest tightness, occasional wheezing, nighttime awakening due to symptoms. He had noted these symptoms previously. So this, according to what we have discussed before, was likely to be asthma. But he remembered as a child he was taken to daktari there with nose problems na akampatia vitu na akakuwa better. So this past medical history is key. So all the tests were done. So what would you do? You suspect asthma, so you look back at this one which I had shown and you go through that algorithm. Is there anything else which can look like this? Does he have other conditions? Is the GI okay? Is the sinus okay? We did a spirometry on this man. And the key thing with spirometry, you look at the graph and then you look at whether they have reversibility after you give a bronchodilator. And indeed, in this patient, after doing the spirometry, he had significant reversibility of 18%. If it is more than 12% change, that is significant. You also check the FEV1 before and after giving the bronchodilator. If it is more than 0.2, that is significant. 0.2 and 12%. So this patient, we confirmed the asthma. And this is how generally a spirometry would look like. And because his symptoms were very frequent, like 2 to 3 times a week, and he was also having problem with sleep, he was already in stage 3, going to stage 4, and he was put on appropriate therapy with some improvement. So key messages to take: asthma is heterogeneous. Asthma may start in childhood, but can start at any point in life. I have had patients who are first-time diagnosis of asthma at age 92. I think that's the oldest I have had. And he couldn't recollect any childhood problems. Why does this happen? It's because our immunity system is a learning system. The immunity I had 2-3 years ago has been exposed to new things and has learned. It's like a police force. Tuko pamoja mpaka hapo. Wacha tuongee maneno ya COPD kidogo tu ndio nimalize. So we are going to refer to GOLD, these GOLD updates of 2023 last year, as well as the Journal of Pan-African Thoracic Society, which I belong to. So COPD is a chronic obstructive pulmonary disease. It is very, very common. Indeed, in Africa, it is very common in women above the age of 60 because wamekuwa kwa moshi. But it is more common in men because of smoking, as well as exposure to different chemicals in their lives, such as smoking industries. They have worked in quarries, they have worked in chemical industries, all those things. Now, the key distinction between asthma and COPD, we said asthma is intermittent, meaning that it will disturb you, keep quiet, disturb you, keep quiet. COPD, on the other hand, is always there. The symptoms are always there, but they may worsen sometimes when one has a COPD exacerbation. So when taking a history, especially in people who are above the age of 50, who may have either of this, or indeed they could have an overlap, you need to ask all those questions. COPD is preventable in that we need to encourage our people to use personal protective equipment, our shoshos and our mothers to open windows in their kitchens. For us who go to different industries, we need to use personal protective equipment. East Africa's prevalence of COPD is 13%. That's a lot. Every 100 people, 1, 2, 3, 4, hapa kuna COPD scala. But you people are young, so less likely. And I don't think I've seen anyone lighting up. Sikuona mtu pale smoking corner. So the way we classify as COPD, there is that due to environmental exposure, but there is also that which is due to genetics. Remember something like alpha-1 antitrypsin deficiency. There are also other genetic variants which cause people to develop COPD. But in general, most people have COPD either because they have smoked or because of exposure to biomass. And we also have a small group which has a COPD and asthma overlap. For example, a fellow is born as a child, he has asthma. Then when he reaches teenage, he starts smoking. See, atapata zote mbili eventually. Now, we must always think about mimics of asthma and mimics of COPD when we are taking our history. So when we have a patient with COPD, think about asthma, TB, all those diseases. In our circumstances, because of TB, many patients develop post-TB fibrosis and COPD. So if you have someone who gives you a history, had TB as a child, please think that they could have COPD because it also needs management. Those are the differential diagnoses of chronic cough. Some are intrathoracic, some are extrathoracic, including chronic allergic rhinitis, postnasal drip, and so on. So differential diagnosis of COPD is huge, including heart failure, reflux, asthma, all those things. We do spirometry in COPD for two reasons. Number one, to diagnose COPD. And what's the difference in spirometry between COPD and asthma? COPD, you have a reduced FEV1, but that indicates obstruction. But there is no reversibility. When you give a bronchodilator, the patient does not get the 12% reversibility in FEV1 that I talked about, and they don't get the 0.2 liters reversibility. In asthma, it's the other way. They have reversibility, except in those patients who are very poorly long-standing asthma. Majority of them will have reversibility. The other reasons we do spirometry is when we are following up the patient, especially if you suspect they may have an exacerbation or they are deteriorating. After we've done our spirometry, we do gold screening, and we have gold 1, greater FEV1 than 80%, and you can look at this. Gold 4 is quite advanced disease, and these patients need to be checked for other things like bullous lung disease, right heart failure, that is called pulmonale. They may have pulmonary hypertension. So the assessment of a COPD patient should check the lungs, but also remember other organs which may be affected, muscular system, cardiac system, and so on. We also ask our patients, how much is this disease preventing you from achieving what you want to achieve, especially in terms of dyspnea. And we have a modified MRC criteria. Grade 0 is a person who has no restriction in activities, up to grade 4, where these people are so breathless they cannot work, they cannot get out of home. The reason for doing this is to be able to classify your patients, and you classify the patients into A, B, E. I move quickly to the goals of treatment in patients who have stable COPD. In these ones, you want to relieve symptoms. They are coughing, they are wheezing, they are short of breath, they are tired. You want to try and reduce those symptoms. You also want to prevent things that may cause exacerbation. So remember immunization. We have flu vaccine, COVID vaccine, we have pneumococcal vaccine. All those are important. If they have complications of the COPD, like they have become wasted, physiotherapy and a right diet, hypoxemic, think about home-based oxygen therapy. They have heart failure, manage that as appropriate. So look for other things that may have resulted as a consequence of the COPD and manage the same. If they are smoking, please advise them to stop smoking. Very, very important. Sometimes it's not willpower. You may have to consider medication or nicotine replacement therapy to help your patients to stop smoking. And even in this group of patients, we follow the same cycle. You see the patient, you assess them, confirm diagnosis, assess their symptoms, then you give them treatment, and then you review later on. And you keep going around in that cycle, tightening until you have optimal care of your patient. What medicines do we use? For many years, we have used the short-acting beta-agonist, that's your salbutamol, and we also use the short-acting things like Atrovent. We have moved a bit now. There are drugs which are available, such as the long-acting beta-agonists and long-acting muscarinic agents. They are now becoming more available. They are expensive at this time, but I know Zydus at some point will bring us affordable medicines. We know you for affordable medicine. The management cycle, you review symptoms, dyspnea, exacerbations, then you assess inhaler technique. For both asthma and COPD, the key to success is inhaler technique. You see that video Shoshu is doing like this, like it's a spray. Many patients even look for a spoon to spray and then take. So be careful about that. Then you keep adjusting your medication. If the drugs are working well, consider reducing the dose. But when do we reduce? In asthmatics, your patient must be well controlled for at least 2 to 3 months before you start reducing your doses. Sometimes you reduce the doses too fast. On the other hand, if your patient gets an exacerbation, you increase the dose quickly, immediately you see them. The same thing applies to COPD. If your patient has had good control over a long period of time, 2 to 3 months, consider reducing the dose. Sometimes you reduce successfully, especially if they've had an exacerbation. Why do we need to reduce the dose? Because of side effects as well as cost of care. Now, the problem sometimes you get is that these drugs are not available. So have a discussion with your patient so that they can get the right medication. The things you should not forget are things that are non-pharmacological, such as smoking cessation and immunization. In patients who have COPD, we must encourage them to exercise because many times they get sarcopenia, they get wasted because they are just sitting there because they don't feel the urge to do exercise. So, take home, asthma, very strong allergy component, less so for COPD. For both these conditions, history. Examination may reveal certain things, wheezing, chest crackles and things like that. Spirometry is key to help distinguish, to help confirm diagnosis and to help distinguish these problems. Inhaler therapy, very important, especially in asthma. We use inhaled corticosteroids. In COPD, we are moving more to LAMA/LABAs. We could talk about the side effects of all these medicines, which are important, but that's maybe for next cycle 360. Now, management cycles that I've talked about: assess, review, adjust. Please remember that one for both of them. And also assess our patients for relevant non-pharmacologic management, especially smoking cessation and vaccines. Thank you.
Thank you very much for that wonderful presentation. Tupige makofi tena. All right, so we have noticed that our history taking is very, very important, yes? All right, so I would like us to introduce and welcome our next presenter. He is an associate professor, consultant family physician, infectious diseases specialist, and director of the HRR clinics. Let's welcome Dr. Mazaher Jafar. Thank you.
Good afternoon, everyone. So as this is coming up, the presentation that I want to make in front of you today is something that combines whatever we've heard until now in one way and is antagonistic to something that we heard as our first presentation. Question: from all those in clinical practice here, as we saw in the morning, how many of us have seen the asthmatics we've seen, the allergic rhinitis patients? How many of us have seen them without having been exposed to antibiotics before they landed on our laps? Most of the times, by the time the patient comes, they've already had some or another antibiotic. But how is it antagonistic to what Dr. Musheru told us? Because very, very interestingly, Dr. Musheru told us, here he's trying to convince the patient to make sure that they take statins, and they want to take it for as short a time as possible. And here we are in the same clinic with the same patient who's trying to tell us, I need the antibiotic. If you don't give it to me, I won't go to work tomorrow. Same patient, sick, same doctor, but now the opposite. Here we are trying to make sure we curb the use of antibiotics as much as possible. So this is what I want us to talk about. How do I as a point of primary care, as a primary care physician, how am I supposed to practice the use of antibiotics in my daily clinical practice? What is correct and what is wrong? And what aspect am I saying it is correct? And at what aspect, or using what proofs, can I clearly say that this is the wrong way to prescribe? So I want us to talk about this, and that's why initially I wrote this. You can see there's a slight change. I had to edit it with a line on the topic. It's actually not about abuse of antimicrobials in primary healthcare, it's about the use. But that take-home message should stay there, that if you don't use it correctly, you abuse it. Before we go forward, I want us to talk in the next 2 slides about primary healthcare family physicians. You noticed when Dr. Angela started looking for the groups and cadres around us, she mentioned physicians, and she mentioned GPs, and many other cadres were there, but one of them that had to be clarified is family physicians. What is this family physician? This is an extract that I removed from a book from a Belgian family physician, Professor Jan Messena. He is discussing primary healthcare from Belgium, and he's discussed it in very, very much depth. And he's discussed it in describing what primary healthcare is about. And when he discusses it, he mentions this in this extract. He says, a family physician is a person, is a clinician who knows or has in-depth knowledge about family members, the people who are under his care, the family who is under his care. Many times as clinicians, we tend to feel we need to have in-depth knowledge of the medicine or the practice of medicine or the pathology or everything else, but we tend to forget that the person in front of us who has come to us for help is a holistic individual. Is not a person who probably understands himself as well as I, as his primary care physician, am supposed to understand him. And that being said, anyone who presents himself in front of you as primary point, you are actually acting as a primary care physician at that point. Even if you're a very, very high cadre of specialists, this person has presented in front of you as a primary care, you will actually be responsible to refer them to the right direction, and you'd be required to understand them more holistically, as we have seen. And therefore we have primary care. In fact, in this extract, if you can read it, I know the text is quite small, you'll find that actually he's describing different tasks which we would need specialized care for, or we would refer for specialized care for today, were actually being done in the 1950s in Belgium by the primary care physicians. So this is what it is, the patient as a whole in front of you, not for only what they've come, but for everything that you think or you are sure that the patient requires. And that means what? That means that the most influential clinician who can be able to influence or be able to guide the patient in the best way forward within the group or network of every patient is their primary care physician. This is what we found. In the 1950s, there was a big move against contraception. Everyone was saying we shouldn't use contraception because it has its side effects, it has problems, etc., etc. And actually we find that in Belgium, and where primary care was very strong in Europe, the primary care physicians stood up and said, no, contraception has its benefits, and we are actually the first pioneers who will talk about it. And we will make sure that those who need contraception will get it. In 1970s, mental health was a big problem. In fact, a lot of people were against the idea of labeling anyone who had clear clinical symptoms against mental health, to do with mental health, as having mental illness. The stigma attached to it was very large. Europe again had a movement by primary healthcare physicians who came in and said, mental health is a problem and we need to be able to solve it. We need to be able to come up with pharmacological means and other means in terms of counseling, etc., to be able to solve this. And this move was seen in Europe in a very strong way. again, it also had effects. So you see, it's not just the patient's illness, not only biomedical causes, even the social illnesses in terms of if you have an economic challenge, if a patient cannot afford your medication, that is a problem for the primary healthcare physician to be able to make sure that it is okay. And that's why something like capitalism, when it came in to Europe in 1980s, there was a big challenge. And the primary healthcare physicians still came up and said, we need to have an alma mater declaration where everyone gets access to care. That's the scope of primary healthcare. Then the point of this whole slide is anyone who is acting as a primary healthcare physician, who is the point of primary care for any of your patients, who will bounce it off you whenever they're going through any medical problem, that person has the best place in order to be able to curb the abuse of antibiotic use by the patient. So I want us to go and talk a little bit about the pre-antibiotic era. Antibiotics with Alexander Fleming and approximately in 1920s were brought in, but before that, how did we get here? There were times when we didn't have allopathic antibiotics available. We did not have this solution available. What happened? How are people still surviving? And that's something we tend to forget in our clinical practice, especially because we have really looked at how antibiotics are easily accessible and many times can prevent a recurrence of a visit for a patient. So convenience allows a person to bring an antibiotic into his prescription, even if it is just a slight doubt. Maybe the patient might have some infection. Let's just throw in an antibiotic. So let's think about this pre-antibiotic era where there were no antibiotics, and we find that there was a lot of death from infective causes. And how were doctors actually handling this situation? It was actually something that was a little difficult. Sometimes there have been documented cases where you have had so much of feeling in terms of not being able to do much for our patients that it has been documented in some cultures. Doctors were actually going and giving emotional support to people who had severe infections, giving flowers, giving things that would enable them to feel better and hope that that will enable them to boost their immunities and allow them to pull through the infection. Also, there were local therapies given. There were mixed herbs. There was this therapy of photodynamic, they call it photodynamic therapy, where you'd actually apply specific chemicals that would work with the sunlight and allow local antimicrobial effects on the areas which you thought there was an infection. Nonetheless, when the antibiotics were finally brought in, before that, we have this as well as other therapies available. Of course, we know that people were being quarantined in one place, and if you made it through, you'd make it through. And you have this option of bloodletting, where you have infections and signs of infection, and hopefully would get rid of the bad blood, which was the misconception in the olden days in terms of why infections come in. And also very important research regarding the Turkish army, the Ottoman army in 1915. We actually found this 1915 era, there was no antibiotics that were being given. And we could actually look at the number of infections without an influence from antibiotics. When you look at that, we find that this was 1 year of study regarding an army in Turkey. We find that a lot of them actually ended up having infections and a large death rate available. Approximately 23,000 people in the cohort had passed away from infections. But the take-home point here was this, that between March 1915 and February 1916, if you look at the type of infections that were available that actually led to the maximum number of deaths, it was from tuberculosis, it was from cholera, and it was from typhoid fever. I want us to look at this slide and think a little bit. In my practice, how many times do I write antibiotics in terms of it being a critical reason for making sure the patient doesn't become septic? And how many times is it something in relation to these infections? Rather, do we see more of the allergic rhinitis type URTIs and give antibiotics? In which case, most probably we did not need to give the antibiotics. So this is Sir Alexander Fleming when he was actually trying to make sure that his antibiotics are working when he discovered penicillin. And he had already foretold during this time, in 1928, that here I am bringing in a weapon against bacteria, these microbes that have been with us all this time and have been conforming to their new standards by natural selection, so that they are able to live within our antibiotic-filled environment. They will become resistant towards our antibiotics. He clearly told this to us when he's just bringing it in. But very few people took heed, and now we are into a new era where we actually have a challenge. United Nations doesn't convene regarding minor issues. Normally it discusses very major issues, and it's normally not very health related. But the United Nations has actually met twice now to discuss antimicrobial resistance in a big way. In 21st of September 2016, it was discussed as a threat to human life on Earth. And at the same time, we've had one just last year in September. So means it's given enough gravity overall, so that the risk is that we might enter a pre-antibiotic era. A post-pre-antibiotic era. What we just saw in terms of the pre-antibiotic era, if you're not careful, we might actually end up going there. This is what has been projected by the UN. That's why we had this discussion in 2024, as well, in September 26th, 2023, in 2024 of September, we are actually having, we had this discussion with United Nations, in regard to antimicrobial resistance, telling us that we really need to focus on this in a big way. So, this is what the UN says, and they're a political institution, so you want to wonder whether it's really very relevant for me in clinical practice. And this is what some research recently showed, where we found that globally, antimicrobial resistance is very big. There is this very interesting calculation done. It's called an NARCI, a normalized antibiotic resistance versus consumption index. This is where we find that a person, a group, an area, a country, you look at the resistant rates of the antibiotics versus the exposure rates in terms of what's written. And you will be able to identify the countries that have a lot of exposure and a lot of resistance. And then we do a ratio to it. And if you look at this map, you'll find the gray areas and the red areas. And I'm sure a lot of us would have expected that Africa would have a lot of red and Europe would have a lot of gray. But that's not what you find, is it? So this is why you don't find this. It's a ratio. Prescription versus resistance. Yes, Africa has huge rates of resistance, but the prescriptions are also equally high. So the denominator has also gone so high that our African market actually shows a gray area when it comes to this ratio. Versus a red area in Europe, what happens is the areas that have even lower resistance rates, but they have very, very, very few prescriptions, because the denominator goes down, we find that the ratio also is quite high. Hope that makes sense. This is also a discussion regarding the same. I wish I would have been able to increase the size of this in my fonts, but it shows that we have a lot of resistance in terms of our antimicrobial, in terms of the different bacteria that are available. In 2019 February, we actually had as high as 80, 70, 50% in terms of the in terms of the bacteria that we find, the escape bacteria in critical situations. And this was something that was gathered from the East African side. So we have a large cohort of resistance showing, and it's not small, it's not in the 10s and 20s of percentages, it's almost 80%. This is a research done within our own Aga Khan team, and we actually found that in terms of the rural prescribing habits of antibiotics, more than 80% of people, of practitioners were actually prescribing antibiotics for simple URTIs, and with or without tests being done. It tells us that we are actually trying to treat the psychology of the patient more than what we really think. It tells us that when a patient comes and asks you for antibiotics, in order to win them over, in order to make sure that they feel like we are on their side, or because we don't want to lose the patient in terms of them not wanting to come back to us, we are actually prescribing antibiotics too often, and that's the truth on the ground. This is some statistics from a referral hospital in Nairobi, where we had we had 95% of patients who were being admitted to hospital having antibiotics being prescribed by the clinicians. And the average duration of the antibiotics being prescribed was about a week. If it was a patient in critical care, it would be between 14 to 21 days. That's a long duration of exposure. Question, is it something that was necessary or not? Also, the most common used in 2018 for antibiotics was ceftriaxone and cefuroxime. I think it's something that, because of renal safety and in terms of easy availability, it's something that was being prescribed a little bit more often. And the change of regimen was normally done only in cases that were quite critical. Otherwise, most of them continued with the same antibiotic regimen until it was discontinued by clinicians. If you look at this percentage, 95%, during that period of 2018, we actually had 2,442 admissions in that hospital. Now, was it worth putting these patients on antibiotics? Was it proven that they needed antibiotics? So if we looked at the patients, we found that the number of patients who actually had, out of the 2,442, 95% of which is approximately 2,100 patients, only 400 patients had a procalcitonin done. And only 263 patients had a culture done, out of which we had the true positive procalcitonins were about 120. So you're talking only 2 to 5% being justified when it came to our antibiotics being given. Why? Probably because we underplay the long-term effects as clinicians when it comes to antibiotics, which is very unfair. I'm not against treatments of any form for any specific illness, but I want to discuss the negative effects of the H. pylori treatments that we are undertaking for our patients. H. pylori has this misconception where a person says, because there's some symptoms, even if you're H. pylori negative, let's just give you any specific H. pylori treatment kit. At the same time, we have this azithromycin push, where even in the pharmacy level, a person says, I have a cough, and Dr. Oweru will attest to this after seeing these patients, that they would have come and they would mostly say, I had the magic once a day, 3-day antibiotic, the azithromycin. And the fact is that this once a day, 3-day antibiotic, has it made an impact on the resistance rates or not? Have we caused any negativity or not? And looking at an outpatient lab that sees referrals from a large area of Nairobi, we find that azithromycin resistance, when it came to 2021, we had 15% amongst the cultures that were drawn. 2022, we had 10%. 2023, we had 30%. And then we had 2024, 20%. In other words, the resistance is going upward, although it went higher in 2023 than in 2024. With levofloxacin as well, from 2021 showing a 20% prevalence of resistance, we actually are at 50%. Question, how is levofloxacin being used? In terms of amoxiclav, it was the worst. We actually had, in this particular lab, 100% resistance to all cultures in 2024. And that tells us that we're doing something wrong. We're writing the antibiotic unnecessarily and it's no longer as effective as it used to be. There was another lab. This is just very crude data from them. And this lab actually covers a bigger area, not only Nairobi, Mombasa, a lot of areas in Kenya, and their cultures that were done. You can find the S is sensitive, R is resistant. And then comes I. Somehow, if you look at the resistant rate for levofloxacin, erythromycin interpreted to azithromycin being in the aminoglycoside group, the amoxicillins and the ampicillins, you will find similarly the rates in the penicillins are almost the same. But when it came to the aminoglycosides, if you look at the resistance rates, you would find that it's actually improved. If you look at the I column, that's what I want us to look at. And I is actually when you talk of the mean inhibitory concentration, any MIC of less than 1, meaning that antibiotic is very potent, we would have that as the best marker for resistance. And if you look at the I columns, we actually find that the I columns, when it comes to levofloxacin, you had the resistance being worse from 2 down to 0, and the azithromycin in levofloxacin, in azithromycin or the aminoglycosides, we have again 300, and then you have the amoxicillins dipping as well in terms of 17 to 9. So these are telling us that we are actually on the ground really dealing with large levels of resistance on the ground. And it's progressive, more than 4 or 5 times higher than over the last 5 years, just because of prescribing habits. And if we extrapolate it, we'll be in trouble over maybe the next 5 to 10 years. There was a study done in Kenyatta Hospital about carbapenem resistance in newborns. And what was done is when the child is born, then the rectal swab was taken. And they were looking at the organisms in terms of their resistance and susceptibility. The resistant organisms in terms of at least carbapenem resistance, we had a 14% in newborns at that time. And then at the same time, we had progressively, by the time the child was being discharged from the hospital, we had a 5 times increase in the prevalence of carbapenem resistance. It means exposure to our hospitals also strongly contributes to our resistance. Now, I want us to quickly analyze why this might be the case. First of all, our surveillance systems question. How many of us have actually noticed that when I go into a hospital and I'm doing my rounds and I'm done with my rounds, I'm actually coming forward and looking at the number of cultures that were done. And I've had samples that were clearly from septic patients, and we still see no growth obtained. NGO, recurrently. When this happens, it breaks the confidence of the physician who is doing the round, who is asking for the culture. Because if I know it's going to be no growth obtained, and the patient is not going to be able to benefit from that culture result in terms of susceptibility, then after first, second, and third try, many times I wouldn't be requesting cultures. It's very important that we have an accurate and representative form of doing cultures in every hospital. If we cannot, then the cultures are not reliable, then we cannot have scientific evidence on how we are treating the patient. We just do subjective treatments. Also, the delayed results, sometimes lost results, tend to cause similar problems. Poor coordination. Also, the fact that a lot of times when a patient is being started on antibiotics, there is not much emphasis given by superiors or by people who are in administration for this practice where we have cultures done, because we feel like it's fine. The patient was alive, we came in with fever, left without fever, so we are successful. We may have given the wrong antibiotic, even though it worked. Even though it worked, we might have had an option of an antibiotic that had a more narrow window, and that would have been a better option rather than exposing the patient to a very strong antibiotic that we gave. So there's a very strong need to focus on this. What are the current approaches to bacterial infections? First of all, a lot of people agree to this, that if you see a septic patient, treat hard. The best antibiotic for septic patients in hospital, almost, I can hear it from the back of your mind, starting with M. So these antibiotics treat hard, yes, but be very careful. Remember that index? In Europe, you go in with septic infection, you know what they do? They're very unlikely to give you meropenem. They're very likely to start you with a cephalosporin or even simple doxycycline for a very sick patient who's got temperatures of 40. Doxycycline start off with. Something unheard of in our current settings. Okay, so you want to be able to make sure that we are actually being scientific about it. Antibiograms, one of the great projects that major hospitals have started on is bringing about antibiograms. It's amazing. Question, when I have the resource, am I actually referring to it, or am I just practicing what I have? What I know works. Am I trying to save my skin by giving the hardest possible antibiotic, and in the long term I'm actually doing damage? We have to be able to understand that our patients will cooperate with us if we explain what we are doing, and we don't have to give the strongest possible antibiotics. And then the third approach is a common approach in primary care. And I think a lot of us can attest to it. You come in, the patient comes in and you tell them you have a fever, I don't know if it's viral or bacterial or fungal or dehydration related or hormone related, but I think it's worth doing some tests. And a lot of times what we'll hear is what we've heard from my predecessors in terms of what was presented. There's no funds, I can't do any test. Will you not treat me? So now we're doing empirical treatment, and in the empirical treatment we have to throw in I won't be surprised if you actually decided to tell the patient, wait 2 days on an NSAID or on paracetamol and have a lot of ginger and honey, and let's see what will happen. Maybe the patient might respect you more than a person who has been giving antibiotics, because even pharmacists who are sitting in the pharmacies are also prescribing the same. So what are the current challenges in contributing towards this resistance? It's unnecessary prophylaxis if I don't need it, and we're seeing the dentists actually trying to avoid that as much as possible. I think minor surgical procedures also are following suit in the same direction. The non-antibiotic effects, for example, there are some antibiotics that are being used by farmers in farm produce to be able to produce more yield. We have heard of that. And that's causing negative effects because exposures are happening at doses which are erratic and which are causing resistance without even the patient trying to take an antibiotic. There's an extremely strong, very strong push towards the misdiagnosis when it comes to extrapulmonary tuberculosis. When it's not in the lungs, but we think there's a swelling somewhere, and because the tuberculosis drugs are free, it becomes very easy as a clinician to write drugs for anti-TB and let's see what will happen in 1 or 2 months. If it doesn't go, if the swelling doesn't disappear, we can always stop. Do you know these are extremely strong antibiotics? And the patient might feel very uncomfortable in front of you, but what you are doing to them by exposing them to anti-TBs without actually having the true diagnosis of tuberculosis. It's a free drug. The government is giving it. 70% of the time when I give the anti-TBs, the swelling disappears. Why shouldn't I would just start on that, and it's an easy fix. I'll actually help the patients. Question, have you really helped the patient? What about MDR-TB? What about XDR-TB? What about the other effects of tuberculosis? When you're talking of the second-line regimens of levofloxacin and other medication used in tuberculosis, what have I done when I've exposed the patients before they actually had TB? Also, these other conditions which we talked about, like the asthma, and there are some other infections which were alluded to by my previous presenters, where they talked about other differential diagnosis of asthma, differential diagnosis of these chronic conditions. One of them is aspergillosis. 2 of them is the walker's cough, where you find a person coughing and coughing and coughing. You wonder, you have checked for TB, it's negative. Should I just give an antibiotic? A lot of us will consider that. The answer is, which antibiotic would you give? What if it's a mycoplasma or a chlamydia pneumonia? Would you consider giving an antibiotic like amoxicillin, which has proved that it's not going to work? What am I dealing with? Why should I just throw an antibiotic in? Where is the science? So it's very important that we also try and encourage diagnostics like procalcitonin use, culture use, etc. I want to spend only a few more minutes. There are new approaches towards infective symptoms. You must be careful and must be able to try and see how a patient might fit into this. Sometimes being able to boost a patient's immunity, being able to trust the patient's immunity is very good and important. Being able to avoid antibiotics by being able to identify the cause. If the person is atopic and is going through a recurrent allergic reactions, using these medicines that we talked about to be able to prevent the reactions may actually prevent the patient from needing antibiotics. If a person is deficient and is getting iron deficiency anemia-related immunocompromisation, you need to correct that. You can't keep giving antibiotics. It's not fair on the patient. Use of probiotics, use of vaccination, it's very, very important. And there are therapies that are being used in terms of how to treat, even when it comes to the H. pylori that we talked about. There is this sequential therapy that's an option where you could actually break the antibiotics into different starting points. So you actually start with amoxicillin or the penicillin, which works on the cell wall. And after working on the cell wall, you actually then a week later introduce, or on day 4, introduce the clarithromycin that works on the RNA and be able to then be more effective. Sequential therapies have proven that you've actually reduced resistance rates from the current effectiveness. Last I checked was around 60-70% of the H. pylori kit. It goes all the way up to 90% just by using sequential therapies. It's quite important that we try and look into these options rather than just quickly switching from the H. pylori kit that we have with clarithromycin and then to a levofloxacin based kit. So what are the requirements for this to happen? First of all, we need to make sure that we have shared decision making. We need to have patient cooperation. Very easy for the patient to walk out of your clinic and into a pharmacy and say, I just want an antibiotic to add on to the prescription. If the patient doesn't understand why you're doing it, you would probably not be successful even after advocating for not using antibiotics. Governmental or institutional cooperation is very important. A lot of these things, antibiograms that have been produced, if people don't follow it, we need to make sure that we have conformity and we buy in people who are prescribing. We also must have cooperation amongst prescribers. Not that one person writes an antibiotic or doesn't decide not to write an antibiotic, and then the patient walks into his colleague's office and the colleague says, okay, I'm adding an antibiotic. What will happen is you have downplayed your colleague's decision, which was actually a good decision to make in order to prevent antibiotic resistance. Also, it's very important that we have a better solution in terms of more robust and affordable healthcare. I think a procalcitonin costs around 4,000 to 5,000 shillings in most hospitals. And it's something that a lot of people can't afford. If it can be made more affordable, that would really help. And I'm sure a lot of manufacturing, lab machine companies, etc., would be able to do so if we encourage it. They work on numbers. If we order more procalcitonins, if we order more cultures, then the machines will come in bigger numbers and the reagents will be cheaper. And then we need to have a dynamic, continuous monitoring system in place. It's not enough to get data that is 5-6 years old. It's not relevant. We need to be able to work together. So take-home points from my presentation is that we need to monitor this thing in a better way. We need to collaborate. We need to develop the power to implement using the institutions that are available. We need to have shared decision-making and make sure the patients buy into the idea after explaining to them the ill effects of abusing antibiotics. We must not underplay the long-term effects of exposure to antibiotics. We need to change the current systems of prescribing. We need to make sure that pharmacies are not able to give out antibiotics unless it's really, really necessary and has been prescribed by a clinician. And we need to consider how we can use probiotics correctly. And we need to learn to prime the patient's immunity as well and prevent the next time a patient will need an antibiotic. By the time we are prescribing an antibiotic, we must consider how will I prevent this patient from coming in again in a short period of time before with needing another antibiotic very soon. And we must prevent and reject any pharmaceutical and patient-related pressures, especially with regard to these antibiotics, levofloxacin, azithromycin, which is really badly being prescribed currently in our country. And we need to improve the culture methodologies in places which are not proficient in doing it. And we must have appropriate dissemination of this information to prescribers so we know. So this is the list of causes of neutrophilia. How many of us would actually consider writing an antibiotic for a patient who has neutrophilia? Most of us. In fact, the main marker when you see a patient did a blood test and has a mild fever that I would consider doing an antibiotic is if they have neutrophilia. Sometimes there was even a study regarding a group of people who had normal neutrophilia. It was normal for their bodies and they were followed up for 35 years. And over the 35-year period, we found that in that group, in that study, it was normal for the neutrophilia to be there. It was not something you would want to treat. Because with or without the antibiotics, they were always neutrophilic. There are also other many factors. One of them here is smoking. If you have a person who is a smoker, you wonder if you have neutrophilia whether you should give antibiotics. Acute events like myocardial infarctions, like other reactions, asthma reactions, we actually have neutrophilia. Will I give them all antibiotics? Am I treating the patient correctly when I give an antibiotic for neutrophilia? So it's still more exhaustive, you can still see. Even something as traumatizing as labor leads to neutrophilia. Should I give every patient who is delivering an antibiotic? These are my references and a short message. Let's do something about the problem before the problem does something about us.
Oh, hello. Thank you very much. I think I'll ask my first question to Dr. Monyo. I have two questions. One is that the treatment of a patient whom you may think has asthma, a patient who has not had symptoms and presents now with symptoms which you think could be an asthmatic event. And one of the challenges that you find is trying to tell this patient that they need the corticosteroid. I don't know how you'd approve that, how you'd approach that. The second question is, as primary care physician, we have the opportunity to encourage patients to do vaccines for some of the immunocompromised patients. Which are some of the patients and which are some of the vaccines that you would recommend? Thank you.
Thank you very much for those very good questions. In terms of managing a patient who has got newly diagnosed asthma, the key to success is education. Once you've confirmed your diagnosis, educate the patient. Then determine how severe this patient is. Some will come with very mild asthma. You remember that staging I had put on top there, there's 1, 2, 3, 4, 5. Decide at what level they are and start appropriate therapy for them. But education will help you win that battle. Always ensure your patient's inhaler technique is accurate. I would refer everyone to the GINA guidelines. I think we have the 2024, it's what I was referring from, GINA guidelines. They are free online and they target management of both parents, adults and children. So that document, GINA guidelines, is up to date. We also have Kenyan guidelines from the Ministry of Health and the Respiratory Society of Kenya. They are available. So, and these are also free online. You can access them. Regarding the second question, in terms of patients with chest conditions, the two most important vaccines are the influenza vaccine and the pneumococcal vaccine. COVID vaccines in some jurisdictions can be given, especially in the West, they are using them. Unfortunately, at this point in time, we don't have the current COVID vaccines in this country. Or is an ID person who can comment.
I completely agree with those two vaccines. Those are the ones that are giving the biggest impact. In fact, I think there is something regarding the flu vaccine in terms of even atopic events when it comes to allergic rhinitis done in the UK, where we find that the use of the tetravalent flu vaccine actually reduced the incidence of either hay fever that we've seen in presentations in the elderly above 60 over the period of, I think, 1 or 2 years in the UK. So it's something really worth giving our patients.
Okay. I have a question. Okay.
Hello. Good afternoon. I'm a GP, and this question goes to Dr. Munyo. Being Gen Z, I have found that my patients are coming and they are asking me, Daktari, mimi niko na asthma, but the moment nachukua puffs mbili za weed, nafunguka. Answer me. Legally, I know it's not prescribed in our country, but what is the effect of cannabis into our patients? And then secondly, what of the issue of vaping and all of that? Because cessation of smoking is now questionable to the Gen Z population. Thank you.
Thank you. Those are very topical things. Indeed, why did we not vote for one of our presidential candidates last time? Your answer would have been there, Now, I did a study in South Africa a few years ago, and we found out that the ravages of cannabis on the lung are worse than cigarettes, both in terms of development of COPD, predisposition to conditions like pneumonia. So it's imperative on us to dissuade our patients from using any inhaled smoke, whether it is shisha, cannabis, cigarettes, vaping. Vaping has been very controversial, but the controversy has died now. We do know that it does not help people kick the smoking habit. That has been proven. We also know that it does not help with preventing people from moving on to become smokers. That has been proven. And we do know that vaping is unregulated. You'll get many people taking some very weird concoctions with almond taste, I don't know, strawberry taste. And we do not know what those chemical failure due to vaping complications. Beyond myself, if you look at literature, New England Journal of Medicine and so on, they will have many cases of patients who have had very bad pneumonias due to vaping. The message is, let's encourage and support our patients to stop smoking, whatever it is they are smoking. And I like what you're smoking.
Thank you. I have a question to Dr. Munyo. Just regarding, my name is Dr. Benga, I'm a physician at Chagora Mission Hospital. So my question, Dr. Munyo, is how do we rationalize the use of, let me start. So I just wanted to know, how do we rationalize the use of antibiotics and steroid, particularly in these patients who are hospitalized because of COPD exacerbation, and sometimes even asthma, because so almost always there'll be a concoction of red 40, ceftriaxone, azithromycin, almost always. And just wanted to know, is it fair to accept that plan of putting them in bread 40 for 5 days and maybe a couple of days of self-triaxone azithromycin. I know Doc is there, but that's basically what happens. So I needed clarity on this. And my other question is for Dr. Just trying to get the name. Yes. Yeah, so this antibiotic story is very, very sad, and we all know that it's the greatest threat to our, our race. But is anything the government is doing? Because today, if I need augmentin, I'll just walk. I'll be like, I just need augmentin 1 gram BD, I'll get it. Are we doing anything at policy level to reduce access to antibiotics via the pharmacies or, and all that? So that's my question for you. Thank you.
Those are very valid questions which we grapple with every day. Short answer. Asthma is not an infectious condition, and therefore, before we use antibiotics, we must confirm that there is an infection, and that infection will respond to I'll use the word antimicrobial rather than antibiotic, because sometimes it is other things, and that infection will respond to whatever antimicrobial we throw at it. Let me illustrate. Majority of patients who come in with asthma, the attacks can be easily traced just by history to things like changes in weather, humidity, dust, polish paint, all those things. And you'll find those patients do not have anything to suggest infection. What are these things? They have no fever, white cells are normal, CRP, procalcitonin, all normal, X-rays normal. So that patient does not have anything at all to suggest an infection. And that is not a patient you are going to be putting on antibiotic. That's a patient you are going to put on a steroid, inhaled. Here we are severe acute asthma. You are going to put that patient on enteral steroids. That is at 0.5 milligram per kilo if you are using prednisolone. So if it's a patient who is 60 kilos, you are going to use 30 milligrams. If it's a child 40 kilos, it is 20 milligrams. So it's not a standard every patient gets 40 milligrams. You give 0.5 milligram per kilo to a maximum 60 milligrams. Note, still 6 hours to start working because they have to go through the stomach, the cells, elaborate those proteins, So whether you give an IV steroid like hydrocortisone or oral steroid in that patient who is able to swallow, it doesn't make a difference. Number 2, there are times when severe acute asthma is precipitated by infection. We have to decide, is this a bacterial infection or a viral infection? With bacterial infections, it's very unusual, but can happen. And in that case, Doc here talked about things like raised white cell count. But remember, asthma is an inflammatory condition which you raise your white cell count. When you do the white cell count, look for left shift. There are infectious granulations in those white cells. And it would be useful if you can do a procalcitonin. It's not 100% accurate, but if you find your procalcitonin is high, then you're most likely dealing with an antibiotic, with a bacteria compared to all the others. But this is still not as accurate as you would want it to be. So high white cell count, high CRP does not always equate a bacterial infection. The only virus we have, there are 2 viruses we can give an antiviral for. One is influenza, and there are simple influenza and COVID tests available. And you can also give a treatment for COVID, steroids and things like that. Number 3, ribavirin can be used for RSV, but ribavirin is not available. I've not seen it in this market for a long time. So when you are thinking you are asthmatic or COPD patient has an active infection, please try and identify what it is and treat appropriately. If it is things like RSV, things like human metapneumovirus, which are so common, you have nothing to offer other than your steroids, your nebulization if needed, and your regular inhaled corticosteroid stroke, long-acting beta agonist. I think that answer is very long. Niachie hapo, si ndio? Iko clear? Now, you talked about ceftriaxone, azithromycin. I think I've answered that one. COPD exacerbations, the patients frequently have infections, but in those also, it is frequently viral rather than bacterial infection. Now, just for general information, before you say your patient has got a pneumonia, please see the X-ray. If the X-ray is normal, most likely your patient does not have a pneumonia. I see many patients, just because they had a white cell of 11, they have been labeled as pneumonia and put on tazobactam, piperacillin, meropenem.
Exactly. And to add on to that, steroids also are a cause of neutrophilia. So when I have a patient who's been on steroids recurrently and then now they're coming to me with a neutrophilia, I should not be beguiled and say, aha, antibiotic. Let's be a little bit precautious. And patients will go your way. They are there to listen to you as the person who is guiding them. I don't know if you've also noticed when parents come with children who have fever, says, give an antibiotic, give an antibiotic. I actually call that treating the parent. Because the patient is not needing antibiotic, but the psychology of the parent is if you don't give him an antibiotic, he's going to fall sick. It's going to take long to get well. Just give an antibiotic. So we really have to not succumb to these pressures and be very scientific about this. So regarding the question on what the government is doing, what our institutions are doing, we have an active move currently ongoing on antimicrobial resistance. There are talks happening, there are solutions coming up, there are monitoring systems coming up. There was something that was done between a collaboration to try and bring about unification of all the data regarding cultures in all referral hospitals. Just recently, I think 2 or 3 months ago, the end result of such a meeting was the clear evidence that there is no significant, there is no trustable data that we have, even in the private sector, because a lot of patients who were very sick, the culture method that was used in the hospitals that were there was not appropriate. So we get wrong results, and therefore we cannot gather and give more weight to that data. But the other important thing that is coming out from such meetings, because of the push, the political push down, is that we are now realizing we need to improve on our methods of doing cultures and the availability of procalcitonins and etc. That push, you all need to play a role in. What happens is this: we are a country that works based on a system where most people pay out of their own pocket for treatment, either through insurance or by themselves. Very few of our patients are actually fully government funded. That being said, any private or government institution lab will work based on numbers because we are interested as a financial institution in making profits. So if you sit down there as a clinician and give the antibiotic without a procalcitonin, without a culture, without any marker apart from a neutrophilia, and you give antibiotics, what happens is that the lab doesn't get requests. When the lab doesn't get a request, then the lab will not stock reagents. Because the last reagent that had 50 tests expired on me. I did 1 test. Do you think that lab administrator will order more procalcitonin reagent? Very unlikely. So it becomes unavailable. But the more you actually prescribe it, you will realize as prescribers, as clinicians, I'm asking for the test, the demand goes up, eventually the cost will go down. The moment something happens more often and it's available, the ideal cost for a procalcitonin, according to some statistics from machines that run procalcitonin, should be between 500 to 1,000 shillings. The actual cost that is being presented to the patient is between 4 to 6,000 shillings. We can make the cost 1/5 if we get the right prescribing habits. So it's actually starting from, because we are not driven by government. It is not funded by government. Government is going to tell you what their recommendation is, but at the end of the day, the actual end result, the practical solution will come based on what's on the ground, and that is being funded by your prescriptions being more. So patients are able to do it eventually because of highest demand and the supply comes in. Now we will have reduced costs. So things are happening, but it's very tough. We need to collaborate. We need to help it to happen as educated prescribers and clinicians, and then we educate our patients. Let's work on this.
My name is Surata Mentana, medicine president at KUTRH. My question goes to the ID specialist. Prof, maybe you teach us how best to prescribe these probiotics, when, and that's one, just a request. Second is many times because of misuse of antibiotic, especially in patient, you end up complication from antibiotic. Like sometimes the patient develop, fulminant Clostridium difficile. We need to treat that with antibiotic again. So you'll find that we don't have like oral vancomycin. I've seen some of my seniors giving, the vancomycin IV via an NG tube. So I don't know where that works. Maybe a pharmacist can also contribute to that.
Yeah, it's a tough situation because with people coming in with multiple drug resistant situations, with C. difficile and other forms of multiple drug reactions, we actually are in almost not able to help, and sometimes we try to actually improve on antibiotics being given using something we call ARBs in the infectious circles, antibiotic resistance blockers. So you actually have things that enhance and prevent resistance by blocking the mechanisms of the bacteria towards resistance. So if it is, let's say, the two major mechanisms that I'm sure we all know, which is one, removal of the antibiotic from the bacteria by the efflux pumps, and two is disintegration of antibiotics. So some are available. Some ARBs, antibiotic resistance blockers, are actually available, like sulbactam. Sometimes integrating it into our antibiotic regimen might actually bring, at the correct doses, at very high doses sometimes considered, would actually bring this multi-drug resistant patient under control. I wouldn't rush a person who is not systemically very ill, apart from diarrhea with C. difficile, onto antibiotics and more antibiotics. I would actually try probiotics because they have a very strong role to play, especially if the patient is stable. And the use of probiotics is a lecture on its own, honestly, because each probiotic actually works the way we know antibiotics. I would strongly encourage all of you to sort of open up some literature regarding probiotics, the Saccharomyces boulardii, the etc. There's so many that you can mention, and each of them have actually been used in patients who have recurrently used antibiotics, and I have cases which have come in and they've responded so well off antibiotics just by bringing in probiotics. Probiotics also play a role, by the way, in H. pylori, because once you complete treatment, when you take probiotics, it has shown very clearly that you've reduced the recurrence, or you have a higher chance of success in terms of treatment when it comes to your H. pylori treatment, just by adding about 10 days of a probiotic after completing your 2-week regimen of H. pylori treatment, which should be necessary to initiate before you initiate it.
Yes, good afternoon. My name is Dr. Mutisia. I have one simple question. Often we forget about topical antimicrobials. Could you comment on the abuse of the same?
I think topical antimicrobials are very important. They do help specific conditions. I haven't personally gone through much data in terms of the resistance to fusidinic acid and the mupirocins. Probably the research is not focusing as much on it because of the fact that it's topical and chances of resistance are anticipated to not be too common. But I believe that being an antimicrobial, topically you want to be able to still make sure that you make the right choice. So it's something that even I would need to look into a little bit more.
Yes, Kileka, I have two concerns. You mentioned something about photodynamic and zero grazing as part of the approaches. Can you expound on those well, so that new to me, then to my colleague Monyu, guide us on the asthma control in pregnancy, because I understand gynecologists are very strict on what to give. Thank you.
Thanks for that question. So the photodynamic therapies actually are therapies that are used, and nowadays even actually if you Google it, you'll realize photodynamic therapies are being used as therapies during for treatment of specific non-metastasized cancers as well. It's basically you use specific chemicals that tend to react to light, and when you have light exposure to them, you actually end up having a cytotoxic sort of reaction ongoing, and that allows some antimicrobial effect. It was much more used as an antimicrobial effect before the advent of antibiotics, especially some descriptions over some Egyptian documents in the 1800s. But then, since the advent of antibiotics, it wasn't much there have been incidences now and talk of how it can be used to enable the use of photodynamic therapy using these chemicals that are not as stable when exposed to light during over very localized infections. As far as zero grazing is concerned, it's actually a discussion. It's not been documented in paper, but a discussion regarding a group collective sort of decision by prescribers in terms of what they should prescribe at one go. So if I'm supposed to develop resistance, probably I would get resistance to one drug. We've seen that happen in some of the areas in UK where they actually described altogether that we will, for any fevers that are unknown, and if we want to give empirical treatment, we will all prescribe, let's say, doxycycline only to start off with. And therefore, if I'm supposed to end up getting resistance, it will be to one drug rather than multiple drugs getting resistant all the time. So it's an approach that we can consider, but we need a lot of collective effort by the prescribers together, and we need to eradicate the dispensing of these antibiotics by unqualified personnel such as pharmaceuticals to be able to curb the misuse of antibiotics.
Asthma is a happy disease. If you manage it properly, you are a happy doctor, you have a happy pregnant lady. Most of the medication we use for asthma are safe in pregnancy, specifically oral steroids and inhaled steroids, stroke, long-acting beta agonists. Do not be afraid to manage your patient properly. Another thing I find is that many times we misuse antibiotics because we find this pregnant lady, we suspect she has pneumonia, but maybe it's just asthma. We can do chest radiographs safely in pregnant women if we do shielding. So if you are thinking you are going to start an antibiotic and you're not sure, and please explain to your patient you are going to shield them, especially after the first trimester, and you can safely get good X-rays to decide, do I want to do an antibiotic or not? And you can discuss this with your radiologist or radiographer so that they appropriately shield the patient. So we should not undertreat our pregnant asthmatics. We treat them appropriately. Thing to note, number one, steroids are safe. Remember, we use steroids to mature the lung at some point, so they are safe. But what we are doing is sometimes prescribing them inappropriately. One is underdosing. You find a patient who has severe acute asthma getting 5 milligrams, 10 milligrams, some are getting 20 milligrams in the morning, 20 in the evening. We use these steroids once a day in the morning. And why do we do that? You remember the steroid cycle? We have higher steroid in the morning in the body and lower in the evening. We are trying to mimic that. So let's say our patient comes to see me at 11 p.m. I give the first dose at that time and another one at 6 in the morning and to continue at 6 in the morning. Rather than nipatie 11 p.m., kesho 11 p.m., that will mess up her cycle. Number two, something I find very frequently, other than underdosing and misdosing, is patients getting tapering doses of steroids. 30 milligrams day 1, 20 day 2, 10 day 3. Umeona hizo Kwa nini tunafanya hivi? Haieleweki bana. If you give your steroids for less than 10 days, you do not need to taper. Unless you are giving colossal doses like we use in some autoimmune conditions. If you are just using 0.5 milligram per kilo per day, and usually in asthma will give between 5 and 7 days, you do not need to taper. So give the first dose at whatever time the patient comes, give the next morning and thereafter every morning for 4 more days or 5 more days or 6 more days until your patient is well controlled. You do not need to taper. Thank you.
I have a question. Good afternoon. My name is Dr. Austin and I'm a pharmacist. I'm sure you've been grossly mentioned today. And it's good that I have to respond. So at the hospital level, we are actually one of the biggest advocates for antimicrobial stewardship. And especially when we find prescriptions with reserve antibiotics, the likes of meropenem, we try to really ask the doctors to really withhold it or at least collect a sample for cultures before we start the antibiotics. And the gospel has really worked with the general practitioners, but the biggest problem is actually the consultants. They are the ones who believe in hitting hard so that I don't know what happens next. So really, what's the approach of dealing with consultants who have that point of view? I think that my question is to the both of you.
At least we have a right to respond. And you are preaching to the converted. But I do recognize what you are saying, and one way which has worked in about 3 of the hospitals where I work is having an antimicrobial stewardship team which is inclusive. So it has pharmacists, it has senior consultants, it has nurses, so that when we decide we are going to ask you to stop your antibiotic, let's say within 3 days if you don't give us a culture. Everybody has bought into that. And then you need to have an advocate, not the legal type, but the antimicrobial stewardship type, who is senior enough to be able to pull their, like, I don't know whether they are surgeons here. They like those very high level drugs for a small abscess, some of them. You need to have a senior enough antimicrobial stewardship person, whether it's a physician or a surgeon, who can call that senior professor and tell them, Professor, hii dawa haina justification, and they can talk on our own. Sio kupigana, lakini someone who will be listened to. Don't get a junior fellow. Okay, I used to be junior a few years ago, like me talking to a professor of cardiology, for example. So the right team is very important, and the team has to be backed by the admin.
Absolutely, absolutely. And to add on to this, when you I'm so happy that you've actually actively seen results, at least with 1 cadre or 2 cadres of doctors who are prescribing. I would advise also that you look at what data is on the ground. Data tends to be authoritative when it comes to, rather than opinions, rather when you're intervening. And if you can actually look at your institution's antibiogram, if there is one, you need to be able to ask, like I've seen some very good practice in some hospitals where they say over the antibiotic page, they say, what is your diagnosis and the site of your infection or suspected site. So if you as a pharmacist receive that page, the prescription page, and you actually refer to that diagnosis versus the antibiogram, you might be able to clearly tell the consultant not only that I think we shouldn't give antibiotics, but if you really feel you have to give an antibiotic, then maybe according to the antibiogram, the better option for what you think is working, what the type of infection you have, is actually XYZ. Not one choice, but 3-4 choices, and then you can see what happens. I think insisting on cultures is a very, very helpful and important way of going about it, and hopefully we have good results coming out, and robust and reliable results. And finally, I think there's this cycle that Dr. Waweru mentioned when it comes to asthma. Keep, assess, review. It is very, assess, review, adjust is very extremely applicable for antibiotic use as well. But now on the acute form, patient has started 3 days ago, assess what's happening, review, is there a way I can de-escalate the antibiotic? You see, if I know the antibiotic is working, as a clinician I feel so good to say, let it go on. Question, could I have reduced or narrowed my window so that I now know the pathogen and its susceptibility? Can I choose something that is less of an atom bomb and more of a very specific sniper to shoot what I need to get rid of in terms of the antimicrobial? So that's the process that if you manage to go through and you review it, you assess, you review it, and you are able to come up with the right solution, you will reduce exposure. Also, duration of use of the antibiotic needs to be questioned. So these are the kind of things where even a consultant who has started into a specific antibiotic will give into because you have used scientific means, and that's what I would suggest we add on to what Dr. Waweru said.
Chair, if you allow one last question, please. My name is Dr. Varvani from County 001. Thank you so much to the presenters and everyone, and I am apologizing. I do not want to stand between you and lunch. But this question goes to Dr. Jafar. Do you think that the overzealous use of antimicrobial hand washes or sanitizers is actually contributing to the antimicrobial resistance we are seeing in our hospitals? Thank you.
It's something that when you have contact-based sanitization or sterilization, I believe it can have local, if it is overdone, it can have local implications. So your hands might actually have some dryness, some problems and all. But when it comes to antimicrobial resistance, if you look at the way that the pathophysiology of how it occurs, the mechanism of antibiotics versus the mechanical way of eradicating through sterilization or through using these sanitizers, I don't feel that it would add more towards the antibiotic resistance because it's not exposure to antibiotics per se. That being said, it's also something you need to be able to understand because after I sterilize a surface, that surface is now completely free of all microbes. You now need to be able to, or ideally completely free, you now need to be able to realize there's a competition per se when it comes to how the antimicrobials will replace themselves over this. And that might change the microbiome of someone. So if I do not only sterilization of my hands, but I use antimicrobial soaps and I use strong sterilization mechanisms recurrently over my body, the microbiome is actually something that's strongly being discussed, and we find that it has implications other than infectious. There's attribution of the microbiome towards immunity, towards mood disorders, towards NCDs, increased risk of heart problems. If you have a change in your microbiome, your susceptibility changes. And so these are the kind of impacts which are negative impacts from over-sterilization.
Thank you very much. I think we've come to our end of the session. Madaktari, asanteni sana. Can you take back your seats? Dr. Joy?
Thank you very much, Aisha and the team. We've had a great morning session. We are headed out for lunch. Walter will take us through the next steps. When we come back in the afternoon, our session chair will be Dr. Bramwell. He's an executive of KFP, and he'll be chairing the session. Thank you.
Thank you so much. I think we are super energized, right? Earlier on, I was just thinking, this is after lunch. How is it going to be? Digestion starting to happen or happening already, but I am happy that we started with energizer. My name is Dr. Sumiyu Bramwell-Wekesa. I'm a family physician and a bioethicist as well, from Kericho County. And I'm also a member of the National Governing Council for Kenya Association of Family Physicians. Karibuni sana. For this session, now that I know we are all alert, I will not give the take-home message. I think I'm a fair moderator. So even as you write your Q&A, make sure you know something that is a take-home message for you, because I'll pick at random, whether from the back or front. One of us will give a take-home message after the talk. Sawa sawa. You need a disclaimer. Thank you. So our speaker this afternoon, he'll have about 40 minutes of presentation. Then we have about 10 minutes for Q&A for his session. Since Dr. Mwaka has given his apologies, and just so to mention, I think we'll plan that his talk is still quite essential. We'll ensure that he gives that talk, so we'll organize for a webinar for the same. Without much ado, our next presenter is Dr. Shabani Jacob. He is an assistant professor and consultant family physician at Aga Khan University, who is going to talk to us about master strokes, the strategies for prevention of stroke in the elderly. Karibu sana, Dr. Shabani. Go ahead.
Thank you very much. Good afternoon, everyone. Yes, I think it's quite apt for me to speak last, and also quite apt to choose an older person to speak about how to take care of elderly people. So we discuss about master strokes, things on how you can master how to manage stroke. I hope by the end of this talk you'll all know how to play golf, and those who like the other strokes as well will be able to perform better once you know how to manage your high blood pressure, your cholesterol, and to manage atrial fibrillation. I think those three things, if you address them when you're seeing older people, will be able to manage to reduce the stroke. I'd like to start by highlighting to you about this study that followed an earlier study that was called InterHeart, which was trying to look at population attributable risk factors for bad cardiovascular outcomes. So InterStroke was trying to look at the factors responsible for both ischemic and intracerebral hemorrhagic strokes in 22 countries. And there were countries in Africa. Kenya was included among the African countries. And I know it's not very clear, and it's not my intention to test your visual acuity, but I've just highlighted to you in red some of the factors that were found to be significant and relevant to our context in Africa. So you find that hypertension across all regions was actually found to be a significant population attributable risk factor for stroke. The other risk factor that was checked was current smoking, and this was not found to be a risk factor in our context in Africa. Was obesity, especially truncal obesity, diet as well. So to go along, in summary, what was followed there was actually a series of slides that was just showing us the different risk factors in interstroke. So all the others, including a sedentary lifestyle, excessive alcohol intake, smoking, elevated cholesterol, and history of diabetes. So of all the risk factors, about 9 of them, 3 of them were found to be relevant in our African context. And that was hypertension, high cholesterol, and for ischemic stroke, the presence of atrial fibrillation. So based on the interstroke study, then we found that it would be relevant if you're thinking of how to address the reduction of risk for stroke in elder people in Africa, that you can focus on these 3 risk factors. The others are still important, but if you're to bet on 3 things, and unajua mambo ni matatu these days in everything, you bet on tackling those 3 risk factors. So on my slide I can say something, but let's just wait until it's reflected on your screens. So those are the risk factors that are at play when you're thinking about stroke. They are related to sugar control, they are related to some of the endocrine disorders, usually also diabetes, cardiovascular disease, chronic kidney disease, and previously called non-alcoholic fatty liver disease, but now called metabolic associated liver disease. And you can see that the other risk factors include increased age, and that's why it's so relevant to discuss about stroke in the elderly, because age is an important risk factor, lifestyle and family history. So let's talk about the risk factors that was found to be contributory in the population. So hypertension. We all know that when you have an elevated blood pressure, you can end up having a burst vessel, so to speak, so the risk of hemorrhagic stroke increases. But you can see, because hypertension is usually in the background of arteriosclerosis and dyslipidemia, hypertension is also associated with increased risk of ischemic stroke. In the clinic that I work in, we decided to look at how good we are looking at people living with hypertension. So since 2012, there's a group of patients we decided to follow up on. So this is the initial findings that they had when we first saw them between 2012 and 2014. Almost an equal distribution between male and female. In that group, quite a number of them had diabetes, and almost half of them had elevated cholesterol. The prevalence of smoking in that group was not that big, but you know, when you ask our patients about smoking, there's a social desirability bias. Most of them might not be willing to volunteer that they smoke, and because alcohol intake is quite more readily acceptable, quite a few of them had ever drank alcohol. So we followed up this group. Initially started with about 755, and we tried to see, do they still remain in our clinic for the next 10 years? And you can see that the attrition rate was quite high. It's a private hospital. Some people change residence, people change how they get the insurance covered. So we couldn't get records of about 550. We finally analyzed sometime late last year going into early this year, this population, and to find out 10 years on what has happened to them. So if you follow them in the cardiovascular risk continuum, so we all started with hypertension as a risk factor, and you can see they also had dyslipidemia and abnormal sugars. And you follow them across. Of these patients that we were able to get records for, 4 of them had myocardial infarction in the 10-year period. One of the patients had heart failure. Remember, we are trying to look at records that are available to us, but in a way it shows us that And maybe we can imply that maybe the care we were doing was improving on their outcomes. The data that we have in terms of the control rate of hypertension was also quite high. About 58% of them had controlled hypertension in the 10-year period. We had 3 patients who had stroke in that one-time period. One of them had one risk factor, which is atrial fibrillation, and then the 2 patients, one had a stroke in the left middle cerebral artery territory, and the other one actually had more TIA. So not many of them also had stroke. So then we're trying to think that probably we're doing a good job following up these guys, although most of them were lost to follow up. We don't have data of those who didn't come back to us. It's possible that they then got stroke where they were, and so it will be important that with advance of electronic health records, we can try and start a new cycle of following people a decade later to see how things are. What's the situation currently? Again, in the same clinic, we are looking at people who have controlled hypertension as an outcome of our care of hypertension, but you're also looking at the processes that we are doing in terms of evidence-based guidance on management of hypertension. So the first group there, we had a small sample. Our intention was to get 30%. When we started earlier in the year, the collection was not as good, but as you can see, the numbers improved as we went along. And pretty good control rates for blood pressure. Against a benchmark, we are using a center in the US as a benchmark in a family medicine practice in the US achieve about 48% control. So we are happy that we are at least going above that, but you can see we are not reached close to 100. And then when you look at the processes of care for hypertension, so how many of our patients get annual ECGs done, how many of them get an assessment for eGFR, and you can see the outcomes are not as good when it comes to ECGs. They are not as, although they are available within the hospital, they are not available within the clinic, and you're trying to get that facility. But this is just to show you that if you're then taking care of people living with hypertension, it becomes very important to pay attention to outcome indicators and process indicators, because ultimately it will show you the direction you need to do to improve the control rate of hypertension. So have there been trials that show that when you lower blood pressure, you prevent stroke? So very many trials, as you can see. Again, not a very clear slide, but a lot of trials have been done in the elderly. For example, PATS and PROGRESS and MISAPIT, and although not very clear to you, but it just summarizes that there is indeed evidence that if you lower blood pressure and you control blood pressure in the elderly, you are able to manage and reduce the risk of stroke. One big trial that was done in China, and this, there were, because the earlier trials that I'd shown you had showed sort of a J-curve phenomenon, when that if you really went very low in your blood pressure, you actually had bad outcomes. And that's why you'll find that earlier guidelines for hypertension had addressed the fact that maybe in the elderly you'll have a higher control or goal, like 150/90, although subsequent trials went to 140/90. So this trial done in China was just basically a systematic review to look at whether intensive blood pressure control achieves reductions in cardiovascular outcomes, including stroke. And they did show that if the more intense you are, the better the outcome. So based on these different scenarios, then it becomes very important to think that the best way to manage stroke is to try and get your older patients to achieve goal blood pressure. And I would like then to address those issues using the recent guideline that came out this year from the European Society of Hypertension. And they mentioned that in our aim to achieve control of blood pressure, that there are 4 tenets we need to think about. First, we must learn and practice correct measurement of blood pressure so that we can actually diagnose many people with blood pressure, put them on treatment and pursue control. We should then learn also on how to assess the patients, especially looking for hypertension-mediated organ damage. And it becomes very important to select the correct therapy targeted at the population you are worried about, and we'll talk about this. And it doesn't rest in you getting patients to the right treatment. It's also important to evaluate your response, and that's why you see the efforts, what you're trying to do in our clinic, to try and collect data on whether we are doing a good job in terms of control rate of hypertension. So for us to optimize blood pressure, we must measure it correctly. And it's important that we know how to measure blood pressure correctly in the office and out of office settings. So the cutoff when you are doing an office blood pressure reading is to try and get a blood pressure less than 140/90. It's very important that you think on the condition of the patient while you're measuring your blood pressure in the clinic, so that the first step is to make sure that you use a validated blood pressure sigmanometer. So for those who work in hospitals, make sure that they are calibrated well, your biomedical teams assesses them, that you use the right cuff size as part of making sure that you're measuring correctly. And also very important, I don't want to belabor the slides because of time, but it's also very important to make sure that the patient is comfortable. Most of us, because we run very busy clinics, we are usually in a rush to measure the blood pressure as soon as the patient comes in. That tends to give you very high levels of white coat hypertension. So it might be worthwhile repeating a blood pressure for a patient whose blood pressure is elevated in the triage process later on in the clinical consult when they are more relaxed. It's important that when you're taking blood pressure and they are seated, that both feet should be on the floor and not crossed. They should not have a full bladder. And we should not be talking to them while you're taking a blood pressure reading. The same thing, kind of advice you give them to when they are doing their home blood pressure monitoring. It's important that their own BP machine should be the one that measures with a cuff at the arm. So we should try to avoid them using wristbands, and also to educate them that wearables, because these days are smartwatches that claim that they can measure your blood pressure, that those give you incorrect readings. In case you are measuring blood pressure at home, the goal is different. So you can have with a cutoff of 135, 85, and then ambulatory BP monitoring becomes an important thing to do. I know we don't have these machines in many of our facilities, but if you have access to them, then it's important to utilize them when you're in doubt of your blood pressure readings, especially in patients with white coat hypertension, so that they have elevated office BPs, but they claim that BP measured at home is different, or those with master hypertension. So these are the ones whose clinic readings are good, but you have evidence of hypertension-mediated organ damage. Then there are also cutoffs for blood pressure when you're doing a BPM, cutoffs during the daytime and nighttime. When you are doing your blood pressure assessment, it's important to look at the history. Please take history of parental history of blood pressure. Do relevant physical examination. That one enables you to find out whether they have hypertension-mediated organ damage, or whether they have features suggestive of secondary hypertension. Do a blood test that can be able to quantify for you hypertension-mediated organ damage. At the very least, do an ECG, creatinine with EGFR assessment, check for blood sugar. If you're able to do a fasting sugar, those are cheaper tests, but if you're not, patient has come to you in a non-fasted state, then glycated hemoglobin, and then do a urine analysis, and with that, an extension, which is urine albumin-creatinine ratio, to find out whether your patient has got hypertension-mediated organ damage or a secondary cause. And sometimes, based on your history, you might do some extended testing. So for example, if you're worried about the features you're seeing in the heart, maybe LVH in a young person, since we are dealing with older people, usually LVH in that age group by ECG is usually correct. You might not need to find out whether it's a true case of LVH by echo, but in older people, you might want to do some assessments to check to see if they have heart failure. Of course, your ECG will be important to look for atrial fibrillation and so on. So the other tests you are seeing there as extended will really be guided by presence of risk factors for secondary hypertension, or if you are trying to find out a little bit more when you're in doubt in some of the findings that you see. So when do you refer to a specialist? That much is dependent on when you're able to use your 3 initial drugs for blood pressure, so a calcium channel blocker, a thiazide or thiazide-like diuretic, and an ACE or ARB. And if you have optimized the dose for that and you're still not getting good control with good drug compliance, then you would want then to refer to a specialist. Have a lower threshold when you are dealing with people with severely elevated blood pressure and evidence of acute heart failure mediated organ damage. So if you have the skill set and you're able to do a fundoscopy, it will be a good thing to do to look for papilloedema in that population, especially in the elderly, and also assess for EGFR and check for things like acute MI or features of early stroke. So do they have a face drift? Do they have a speech disturbance as one of the quick way for assessing for stroke? It's very important that you categorize your blood pressure, and as you can see, it's not just dependent on the blood pressure reading, it's also dependent on the presence of risk factors, and you can see where it's in red, very high risk. For example, if you have a lot of risk factors and associated clinical conditions, even if your blood pressure is just mildly elevated in 130/70, this patient is in high risk and should be put on treatment. The selection of therapy is usually guided by the risk categorization. So those with very high risk would usually put them on medication. Those with low to moderate risk, you should try to confirm their blood pressure reading at a second time. So this is new guidance coming from ESC, because they have realized that sometimes you are over eager to treat based on one clinic reading in the clinic, that if your patient is not very high risk, then take time to confirm the blood pressure reading. And that second reading can be a home-based reading or ambulatory BP blood pressure monitor measurement. For all patients, whether they are low risk or moderate risk, and you've made a diagnosis, then initiate lifestyle measures and immediate drug treatment for those who are high risk. Then the selection of therapy is, of course, dependent by some lifestyle measures that you should be able to do. Most of us are primary care physicians and family physicians, so I know you're all very good with lifestyle measures. It's important that we embrace this and encourage this from healthy diet, no smoking, reduction or cessation of alcohol, and creating supportive environments where people can exercise and lose weight. And increasingly, people are realizing that some environmental factors like noise and air pollution increase blood pressure. So this should be addressed. For those who hold county positions like Joy, please talk to your people in Elgeyo and Nakuru. We need to reduce pollution. Very busy slide, but just to summarize is that the treatments that we choose to guide your therapy for hypertension will be dependent on the presence of other associated clinical conditions. But as a general strategy is that we want you to start anyone you choose to treat with blood pressure with combined dual therapy. So the change is that most patients will do well when you start with combined dual therapy. Because you're talking about hypertension in the elderly, a few of them might benefit from monotherapy, especially if they have isolated systolic hypertension and very many comorbid conditions. But for majority of people, is combined dual therapy. And in Africans, the dual therapy that works very well is a RAS inhibitor plus a calcium channel blocker, or a RAS inhibitor plus a thiazide-like diuretic. We also have a third option. Sometimes in Africans, calcium channel blockers and thiazide-like diuretics work very well to lower blood pressure. It's important when you're seeing older people with blood pressure to start categorizing them depending on frailty. So those who are fit, so if you're treating me and my fellow barber who is running for the AU presidency, you probably want to assume that they are fit, and therefore you can have tighter goals and be aggressive. For those who are slowed down by autonomic dysfunction and severely dependent, you might have a lower goal like 150/90, and you might be cautious on initiating your therapy so that you can do monotherapy and step up to dual therapy at lower doses. So this then tells you that once you put them on treatment, please evaluate their blood pressure. So aim for the control you've desired for your patient, then have a schedule in a timely manner where you monitor their response to the treatment. So once you start treatment, don't forget about them. Don't give them very long appointments. Initially, when you start, you might want to give an appointment within 2 weeks to see that if they are tolerable to the medication you've chosen. And then you can give them an appointment again within 3 months to check whether they are moving towards your goal. If you can, and that should be the desire, aim for control within 3 months. So that's hypertension. The other risk factor that was found that promotes the risk of stroke in older people is high cholesterol, and the Interstroke study summarized that data that elevated cholesterol increases blood pressure. And there have been other studies increase the risk of stroke, and there have been other study where somebody looked at the risk of stroke when patients have got high cholesterol in Africa, and combined for both stroke parameters, both ischemic and hemorrhagic stroke, the risk was increased. And if you then looked at the forest plot more critically, it looked like the risk was increased in hemorrhagic stroke, surprisingly, a little bit more than ischemic stroke. So have we done anything in our clinic to try and find out that? And maybe you had seen this slide earlier from Sam, is that you're also trying to look at how good we are at outcome measures for cholesterol care in a family medicine practice. So we are looking at our starting prescription rate as a process outcome, and you can see that you're probably over-eager as practitioners in prescribing statins. We did that a little bit more in the month of February, April, May, and June. but you are not achieving the control. So although we are prescribing more statins, we are probably not using at the right level of potency to give us goal attainment in terms of cholesterol control. And we are improving the cardiovascular risk outcomes for these patients, but not as much as we would want. And this is a very basic slide that shows what guidance to use. But just to encourage you that if you want to prevent stroke, please choose to screen people who are at risk for cholesterol. So those who are obese, those who have hypertension, those who smoke, those who have family risk of atherosclerotic cardiovascular disease. But also, when you choose to treat, create targets for yourself so that if you are low risk, you have a target of lifestyle measures. Then if you're moderate risk, you'll start treatment. And then if your risk is very high, you initiate treatments and try to aim to achieve your goal LDL value in 3 months. For those who already have had an event, then they're already identified as high risk. Your LDL goal should be 1.8. And if you want to prevent stroke, then be aggressive. You can see that if you're slightly younger, older person, so from 50 to 75, you can do combination statins. For those above 75, you can stick with a single statin, moderate to high dose. And then if you're in a center where you have lipid specialists, then you can get them referred for where you want higher goals. I'll recommend for all of us to use the Eastern Africa WHO cardiovascular risk score tool. It's a simple tool to use. It's a color-coded chart. It has both lab-based parameters and a non-lab value. And concordance studies have shown that especially for those at high risk, it picks the risk profile in the same way. And we're trying to look at a study on wellness patients to see those who are at low risk, whether it will also pick in the same way in the institution I'm working. So pick a tool that enables you to find the cardiovascular risk and treat your cholesterol to goal. In older people, the challenge of lowering cholesterol is usually a balance. There isn't a lot of evidence out there on studies because traditional studies don't look at very old people like people above 75. And therefore there is insufficient data out there. But practically you're guided by frailty, so a fit older person, you can try to reach those goals we talked about. Sometimes practical considerations in older people include the increased risk of adverse effects like statin-associated muscle symptoms and the disability that arises from the fact that if they're in pain with the muscle aches, they'll probably stop using the medicine. The bigger national and cost-effective analysis studies are wondering, is it worthwhile treating somebody who is maybe 80 with cholesterol lowering medicine? What are you really trying to achieve? Maybe at that age, we should let them die and allow younger people to live. But if you are altruistic, I don't think you would want to let older people die. So let's give them statins, especially the ones who are fit. And it's because there's evidence that if you lower the LDL, you improve outcomes. Again, as I mentioned, that there are age-dependent guidelines, and most tools are available for you to use. And some of the tools you can use in older people, even above 75. The pooled cohort risk assessment tool has allowed you to go for people older than 80 in terms of assessing cardiovascular risk. And there are interventions that show that dependent on the risk profile you put someone, some will do lifestyle, but those who are in the red corner, you should be very aggressive in treating their risk. So about food, you should try and give the older people a wide variety of food. Don't be too focused in some of the we call them fat diets. For example, the ketogenic diet or the very low carbohydrate diet might lack some micronutrients, and in older people, micronutrient health is important. So go for portion control balanced diet as ways to manage people with lipid disorders. But try to reduce the alcoholic intake and try to reduce foods that are very high in added sugar and therefore goes for the processed foods. And I'm glad I've spoken about this talk after lunch. And choose your gun correctly, which means you want to make sure that dependent on your risk category, if you really want to reduce the risk of stroke, go for high intensity cholesterol lowering medicines if they have increased risk. And this is just a summary of the statins that we have in our country. We have atorvastatin, rosuvastatin, and pitavastatin easily available. And you can see, depending on the doses, where they all land. In some of the patients who are very high risk, for example, an older person who's already had a stroke and you want to prevent another stroke, then you might need to use combination therapies. And all this is just to show you that when you reduce your cholesterol and by using statin therapies, you improve on your outcomes. And very many studies across the board have shown a benefit of trying to do this. And the more aggressive you are with the guidelines, the more you have. And you can see increasingly the realization that combination therapies for lipid lowering treatments can give you very good reductions, and that informs sometimes for us that in specialized lipid clinics, so that you can get those people at very high risk to these combination treatments. So that is just to summarize from different scenarios what we need to do. And there's a summary guideline for the European Society of Cardiology on how we should treat older people with elevated cholesterol. Those with the highest level of evidence is that we should treat them in the same way we treat younger patients. So I think this is a very big recommendation to change the way we practice. And for primary prevention, again, we should look at the level of risk in the same way we look at people who are less than 75. So in a way, a lot of the guidelines are now saying, let's be as aggressive with older people when it comes to lipid lowering as we are with younger people. So in summary is that you want to think of risk assessment. You want to do your risk assessment to guide your choice of therapy for lipid lowering. You want to make sure that you have available statins at the very least. And for most of us in primary care, let's get comfortable using statins, optimizing the doses, and then maybe using with another lipid lowering therapy as a second line if you're not achieving goal. And then if you're using 2 drugs and you're not achieving goal, you can refer them to facilities that have got lipid specialists. What about diagnosing atrial fibrillation and preventing stroke? We know that there are a lot of bad outcomes when it comes to atrial fibrillation, both to the healthcare system and society, and also to patient groups. I think what is sometimes key when you are thinking about atrial fibrillation is to adopt a multidisciplinary care model that has been summarized there as CARE, where the C is to assess the comorbid conditions and risk factor management. So, and this can be done by us in primary care, those in cardiology, and our nursing colleague. A is to avoid stroke, and R is to reduce the symptoms, and E is to do proper evaluation. And all these approaches starts from screening to optimizing treatment for those who are found with atrial fibrillation, and creating follow-up care options. Again, a very busy slide, and I'm sure a challenge to a visual acuity, but just to summarize, for us is to say that have a centralized pathway for getting patients whom you diagnose with atrial fibrillation, looking at how you assess for risk factors, starting the assessment using the tools that we normally use to see the risk of developing stroke. So most of us should familiarize ourselves with the CHAD-VASQ2 tool so that to determine who needs to be on anticoagulation therapies, and also the Hasbled score, which is the score that determines the bleeding risk. And then get to refer where you have a challenge, for example, in an older person, where you find it very difficult to get access to good anticoagulation and good medicines for rhythm and rate control like beta blockers. It's important to remember the comorbid conditions that increases the chances of you getting atrial fibrillation. So excessive alcohol drinking, lack of using of medications to manage the primary disorders. So those with diabetes should have their diabetes managed well. Those with hypertension should have their hypertension managed well. Assess them. Most older people above the age of 75 will need anticoagulation, and you have the entire spectrum from warfarin if it's easily available. Some of the challenges of warfarin is, of course, the need to monitor your INR. So the newer anticoagulation drugs take the risk, the challenge of monitoring the INR away from you, but you realize there's a challenge of cost when it comes to that. So the president has his mambo matatu. I have mine. And for me, I would say, when you are thinking of these three conditions, hypertension, dyslipidemia, atrial fibrillation, address them conclusively, and then you will not send them to heaven. Talk with the world and the government to ensure that you have got good system-based methods of changing things and risk factors that affect the community. Then you'll probably get a lot of people getting good care. And don't just think about your individual patient, think about the community they live in and what the government does. Because there is really evidence that if you do all these things, you'll be able to manage your patients with and reduce the risk of stroke. Try to develop simple tools that can improve recall to drug adherence. So if you're autistic, you can draw this. But the newer guidance from the European Society of Hypertension, I can give you some of these charts so that you can give to your patients so that they remember which drug they are to take in the morning, which one they are to take and for what reason. And encourage lifestyle changes by being very good at motivational interviewing. I thought that I'll give you this question, but I think I'm looking at the time and Arsenal is about to play. So we'll not go so fast with this. But what are the take-home messages? If you want to prevent stroke in older people, those with hypertension, please get their blood pressure well controlled. Have a system of defining who needs to be on cholesterol lowering treatment, and for most people the cholesterol lowering treatment will be statins. Initiate this and treat to goal. The new European guidance gives you the courage to approach the older person with the same rigor as you do younger people, so treat them to goal and use the medications. These side effects are not as common as we worry. And assess, which means for older people, please do at least a baseline ECG. That will be one of the ways you could easily assess and detect atrial fibrillation, and also teach your nursing teams when they are doing triage that if they pick abnormal blood pressure, heart rate rhythms, if they're using automated blood pressure machines like the Dynamap, when you have atrial fibrillation, it actually doesn't give you a good blood pressure readings. It keeps fluctuating. So the machine is not dysfunctional. It's probably that your patient has got atrial fibrillation. So thank you very much, and I'm glad that you've listened to me, and I'm welcome for questions.
Thank you, Dr. Shabani, for that excellent teaching. There were lots of pictures, and towards the end, there's also a big cartoon on the slideshow, which I think kept us awake. Please don't sit there. I'd like you to come to the stage and take your seat here, because you're the only presenter this afternoon for these topics, so that we can start the Q&A session. And even just as I promised, I said, if I know you, I think it will be much better. So I'll start this end, and I'll ensure we have gender equity. I think I had said your take-home message. And since I know Atea, Dr. what was your take-home message for this afternoon?
The take-home message was to, first of all, learn to identify atrial fibrillation, assess it, and manage it.
Thank you very much. We'll go to this side. One more. Please prepare your questions. We'll have maybe a few minutes of Q&A. Yes. Your take-home message, Dr.
Thank you. My take-home message is that the first priority should be you lower the BP of the patient, take it seriously, do lifestyle modification, then treat the high cholesterol and detect atrial fibrillation soon.
Thank you. That's a good summary, Sante. Thank you. We'll go ahead and take questions in the house or on the floor. Any questions? Please, someone will help with the microphone. You will have this one, Dr.
Thank you, Dr. Ali, for the wonderful presentation. I think it was quite inspiring and eye-opening. Mine is maybe, I don't know if it's a question or whatever I call it, but I would like you to tell us if it's the same cutoff for cholesterol for everybody, and if not, then what would you use as your cutoffs, and which specific types of cholesterols would you look at in terms of stroke prevention, both primary and secondary?
Okay. I think it's a very excellent question. So if the elder person you are saying has never had a stroke, so we are talking about primary prevention, then it's important that you carry out what is called a risk assessment. And as a guidance for people who are trying to do primary prevention, risk assessment starts by first asking yourself to just confirm that they have never had an event, because then it becomes secondary prevention. So the first thing is that, do they have any evidence of established atherosclerotic cardiovascular disease? You can ask them, because some of them will remember that they've had a stroke, heart attack, or you have been involved with their care, so that you will know. But many older people sometimes have silent events, especially myocardial infarctions, and they might not know about it. So doing an ECG to look for Q waves can be helpful to find out whether they have had a previous myocardial infarction. Increasingly, people are doing assessments to, especially in older people, at the carotid artery to look to see if they have any evidence of plaque or coronary atherosclerosis. But assure yourself that they do not have a secondary event as the first thing. The second question you need to ask yourself for people with when you're trying to do primary prevention is whether they have type 2 diabetes. So check for diabetes. Although the evidence says for people between the age of 40 and 75, increasingly we are looking at older people above 75, also with type 2 diabetes as eligible to be on statins. The third thing is how high your lipid profile is. So you should, and we encourage people to do non-fasting lipid profile because it gives you the actual state of the patient, how they are most of the time. So when you do fasting, of course, sometimes you can affect some certain values. Fasting should be indicated when the TGs are very high, more than 4.5. But for majority of people, if you do a non-fasting value, you can check your LDL. Anyone with an LDL more than 5.9 should be on cholesterol lowering medicine, usually high intensity cholesterol lowering medicine, high intensity statins. And then I've shared with you a tool that can allow you to look at your cardiovascular risk. The WHO tool ends at the age of 75, but the other tools like Q-Risk if you get an older person. So if then you determine that truly this person is primary prevention, then using your risk score, you'll be able to determine whether they are moderate risk or high risk and very high risk. So for those who are moderate risk, you can aim for an LDL goal of 1.8 LDL goal, or at least achieve a reduction of 50% from their baseline LDL. For those who establish to be very high risk, you can go for a lower goal, which is 1.4. So for secondary prevention, it's very easy. So secondary prevention, they are considered to be very high risk. For them, their goal is to have the LDL less than 1.4. So that's a challenge in most of the patients that we see, because most baseline LDLs are around 3, 4, and therefore you need very potent lipid lowering medication. And you'll find that to get to 1.4, you most likely you'll need to use combination therapies, so statins and something else, ezetimibe and so on. I hope that has, in a very long way, answered your question. Thank you.
Written questions for you. We can start with this one.
So this is a statistician, so he's asked what is the number needed to treat for statin therapy in those elderly more than 75 for primary prevention of stroke. So I don't have a number on my head, but increasingly what is coming out, looking at the guidance from European Society of Dyslipidemia, is that with a level 1A evidence, that we approach them in the same way we would approach younger people. So for primary prevention of stroke, then you use your risk assessment, and if it is a high risk patient, then you go aggressively the way I've spoken to when I was answering the last question. Then there's a question that says, I kindly comment on secondary prevention of stroke in a patient who has had both hemorrhagic and ischemic cardiovascular cerebrovascular accident previously. First of all, that's a very sick patient and a very unlucky patient. But the secondary prevention goals remain the same. So first of all, manage their blood pressure to goal. Initially, there was advice to try and aim for less than 130/80. There's sometimes a challenge when you do that because you risk hypotension. So you want to be careful that you don't drop below 120 or below 110/70. But if you can safely lower it below 130/80, that will be a good goal. But at least make sure that they're below 140/90 when it comes to blood pressure. And then for their lipid goal, you need to get them to less than 1.4 LDL, or at least more than 50% drop from their baseline LDL. You are likely to achieve this when you use high-intensity statins in combination with another lipid-lowering medicine. So, for example, high-intensity statin plus ezetimibe. If they have diabetes, then manage their diabetes to goal, which is to aim for HbA1c at least less than 7%. If you can get them safely to less than 6.5, then that's better. They need to be on aspirin, of course, to reduce the risk of getting a repeat ischemic event. And then some of the good blood pressure medicines will be potent in our African setting. We'll be having a calcium channel blockers. Good studies on amlodipine with the risk of recurrent stroke. And thiazide like diuretics also have good studies to back them up, as well as ACE inhibitors. This is a patient I think in primary care you would want to work with a specialist. So based on the patient you've seen before with the bad presentation, yes, so they had a bad outcome, which was to have a second cardiovascular ischemic event and died. And I think one of the things I probably had missed was to try and look for atrial fibrillation. If you're having repeated strokes, search for atrial fibrillation or risks for it. So an echo to look for a cardiac emboli will be an important thing to check. So we have a question that says, is a typical writing for a doctor, but the patient gets tired of, can you try and, so there's a question on how do you deal with patients with isolated diastolic BP elevation? Is this enough to diagnose blood pressure? And if yes, how do you go about it? Yes, so isolated diastolic hypertension is still hypertension. There are a lot of guidelines and new guidance in the same summary document from ESC, especially recognize this conundrum of isolated systolic hypertension, especially in younger people. So there are a lot of studies and there isn't a lot of direct recommendations on which medicines to use, but a recognition that it should be managed as hypertension, but with a little bit of caution on how you institute your therapies, because if you go very aggressive with triple therapy and so on, you tend to get hypotension by further lowering the systolic hypertension and the diastolic hypertension. Is emergency, urgency hypertension? What are the current guidelines? The quickest way to remember what is emergency hypertension is when there is an associated acute hypertension-mediated organ damage. So usually these people come with markedly elevated blood pressure. If you want to check for emergency hypertension, then do your ECG to see any evidence of acute coronary syndrome. If you have the skill set to do a fundoscopy, please do one and check for papilloedema. A check for acute decompensated heart failure. So this we can find out clinically by checking to see if there's tender hepatomegaly, raised JVP, but you can also confirm it to the lab by checking whether there's raised BNP, and you can do a POCAS and check for ejection fraction and things like that. But for many of us in the clinic, it will be a clinical diagnosis based on checking for papilloedema. And then if you have a quick ECG, you can check for it. If it's an emergency, for example, hypertension in pregnancy is an emergency. If you have features of neurological deficit is an emergency, and confusion. So these are patients who should admit and manage for their blood pressure using IV medication under monitoring situation, so ICU care. Urgency means you have the liberty to reduce the blood pressure in the next 24 hours or so. Usually this will again be people with high blood pressure but without any evidence of acute HMOD, but they have some evidence of maybe LVH and things like that, so that you can bring their blood pressure down slowly. There is guidance for that. For emergency is IV medication. For urgency is to try and get them back to the medicine that previously used to control them. And with urgency, don't panic. You have about 24 hours to control their blood pressure. So there's a question on whether statins are indicated for thromboembolic strokes without other risk factors, and the quick answer to that is yes, and you should use high-intensity statins. So if you're using rosuvastatin, the statin dose for that will be 20 to 40. If it's atorvastatin, then you're talking 40 and 80. The other one in the market, it does not have the right intensity. And even in this, people should think of combination treatments. So you're starting together with ezetimibe, with bempedoic acid, and then refer them to lipid clinics where they can use some of the injectable treatments like inclisiran and the PCSK9 inhibitors. Sometimes you have to use up to 4 drugs to get these people getting to goal cholesterol. So what causes stroke, hemorrhagic stroke? Is it both systolic or elevated diastolic or both? Most of the studies have actually put the increased risk of hemorrhagic stroke due to isolated systolic hypertension. But you'll find in most patients who have very high systolic hypertension, they also tend to have very high diastolic hypertension. So I'll say both increase usually to grade 3 hypertension, and then also sometimes when there's a rapid change of the blood pressure. So is it correct to say that those with gout will need primary or secondary prevention? So hyperuricemia is usually a very common finding in those with hypertension. So it's independent for a risk factor for hypertension, not stroke or MI per se. So it's something you need to address in the regular care of people with hypertension. And also let's remember that hyperuricemia increases your risk of getting kidney stones, and obstructive uropathy can easily lead to chronic kidney disease. So it's a factor not to be ignored, but if you're looking for a direct causation for stroke directly, there is no evidence to find that it does that. Good. So the writing I couldn't read has been clarified because it's such an important question. How do you motivate patients to take medicines for conditions that are asymptomatic? So the question was put this way. Many patients get tired of taking medications, especially if they have no problems. So how do we handle this? I think if we start this now, it will be the time when Arsenal has won the league. But in short, let's learn techniques of motivational interviewing. Let's try to deal with ambivalence. And I gave a summary called OARS, O-A-R-S. So when you're dealing with patients, please try to find out why they do not want to take their medicines. Address ambivalence, deal with the resistance that they are showing, and give them support. Don't be very prescriptive and dogmatic. It's not very easy not to take medicines for conditions that don't give us pain. In our future life, when we reincarnate, maybe we should pray that hypertension and dyslipidemia becomes painful conditions, then we'll win this war. Kindly comment, this is asthma. There are questions about asthma, so I'll skip them. So this is a very good comment from the management of atrial fibrillation. So in patients with confirmed AFib, especially patients with valvular heart disease, be sure to give digoxin in the absence of premature ventricular contractions and bradycardia. Give your low-dose anticoagulants, also necessary, especially in symptomatic cardio patients with low-voltage QRS complexes on ECG, and those with reduced ejection fraction on echo. I think we are grateful for that contribution. So the question is about aminophylline and asthma, and antihistamines and asthma. I've seen Dr. Munyo has disappeared. Maybe we can pack that. So when do we use low intensity statins? Not very much, but in limited situations. One, when your patient is not tolerable to high intensity statins, low intensity statins and lifestyle can have a limited role. However, that's a big gamble because you might not be able to get to goal cholesterol treatments. Can start doses to very high BPs lead to high chances of getting ischemic heart disease? And if so, how do we handle this in primary care levels where admission is not possible? So I think the question tries to address the situations where you are faced with elevated blood pressure readings. I think the first thing you should really try to find out, does your patient have hypertensive emergency? It's not advisable to try to lower blood pressure aggressively in a setting where you cannot monitor the blood pressure and you cannot give titrable medication. So the practice of giving sublingual nifedipine, Lasix to lower blood pressure is discouraged. Try to get your patient to a center where their blood pressure can be monitored. Because if they are getting a stroke and you are in a clinic somewhere in Kericho, you will not be able to manage their stroke in your clinical setting. So recognition of hypertensive emergencies
is very important. And I think one of the big take-homes is if we can all improve on our clinical skills to look at these risk factors. If your blood pressure is elevated, does your patient have a stroke? Does your patient have an acute myocardial infarction? Is your patient pregnant? These are the patients who want to refer to the clinic before doing anything else to assess. If you have the skill set to do a fundoscopy, do it and look for papillary, because that is the only thing that will do with eye symptoms that differentiates from urgency from emergency. But many patients with papilloedema will already come in complaining to you of blurred vision, and any person with hypertension and they are confused actually have an hypertensive emergency. So hypertensive encephalopathy is an hypertensive emergency. So that's what I will encourage. Even if you are far away, you are trying to get them to a facility that can take better care of them. So no heroic or cowboy maneuvers in clinics. So what is the role of surgery in the management of ischemic stroke, especially in Kenya? And how common is carotid endarterectomy in Kenya? Is Arsenal going to win the EPL this season? The answer is yes, and there is evidence about it. But to answer the first question, there is centers that are stroke centers that can do advanced procedures to manage stroke. The key is to get your patients in a timely manner. We usually say time is brain. In the institution I work in, there is a good stroke protocol and pathway that encourages people to quickly recognize stroke, to get the CT scan done quickly within 45 minutes and interpreted, so that they can determine whether this is an ischemic stroke or a hemorrhagic stroke. And then if there is an ischemic stroke, there are all these advanced ways, not only thrombectomy, but also removal of clots, doing carotid endarterectomies, and opening and busting up clots, and all those surgical methods
that can be done in a stroke center available. Thank you. Yes, this is a comment, and I think I've spoken about it, and we are thankful about the comment in how to manage AFib.
Thank you very much, Dr. Shabani. You've done an excellent job in presentation and answering all the questions. Thank you so much. I'll ask you to take your seat. Yeah, I know now we are eager we were given a quiz puzzle, to answer. They promised that there might be something coming. So I think my work is more or less done here. I'd like to welcome Kevin so that he takes us through the next session. And I see gifts are shining on the other side.
Thank you so much, Dr. Smiu. A round of applause for Dr. Shabani. The questions are quite many, and I really want to thank that he was able to respond to all that were raised. And also we've noted that Arsenal might not be able to win this coming season. So we still continue to press on for the 20th year. Now, it's the time that we've all been waiting for, but allow me to give two quick announcements. The team from Kisumu, because I'm aware that their flights is almost, so Team Kisumu, the Lake region that is, and the North Rift team, you are requested to be at the booth at this time so that we're able to facilitate on how we are able to arrange the transport logistics so that we cannot miss on our timely flight. So that's an announcement that I'm good to note. That is Kisumu team, North Rift team, and the Lake region team. Mombasa team will be leaving Coast region team, that is 5:30. We are all the regions represented here, you can imagine. Central, Nairobi, Rift, North Rift, Lake region, Coast, all regions were represented. Another one, I know some already might have left, but I want to say that next year we're going to do it in a bigger way. That is Care 360 Conclave 2.0. So 2.0 is coming in a bigger way, and mine is really to thank you so much for your patience. I know there are those who came here right from 8:30 till now. It really means a lot for us, and we really want to say a big thank you. For those who are leaving, we are going to have some gift packs. You're not going to walk alone. That's a good news, right? Yeah. You're not going to walk alone. There are some gift packs that have been there waiting for us. Please grab one as you go. They've been nicely packaged. Please ensure you pick one. In fact, there will be some guys just to ensure whether you don't. We love to ensure that you carry one as you go. Then please also be reminded that if you've parked in the basement, ensure you validate at the 8th floor before you go down. Right? Good. So this is the man cometh the hour. I want to take this opportunity to invite Mr. Kevin Ohome, our product manager, Zydus Life Sciences, who is going to take us through the raffle. And I'm sure the gifts are ready there. We'll be gifting you. Thank you so much. I was your MC of the day, Mr. Walter Gada. Thank you so much, and God bless you.
Thank you, Walter, for taking us through throughout the day. That's a good job. My name is Kelvin Ohome. I support the teams from a marketing perspective, that is for Kenya and Tanzania. So, I'm a brief person, I come bearing gifts. We have 7 gifts, from a Master 3 stethoscope all the way to a 42-liter microwave from LG. So you can imagine what is in between, the first and the last gift. Okay? Great, so I need some help if I kindly call upon you to help me do the raffle. In Swahili wanasema mganga ajigani, isn't it? Yes, and I want to be very fair, very transparent. We keep on seeing people coming on TV and they keep on repeating the same thing. Everybody says the law is very clear, isn't it? Even me, I say the same thing. The law is very clear. Great, so for the first gift, I will call upon Dr. Bramwell. Kindly come help me do the raffle. So the rule is very simple. You have to be physically present.
I'll pick my own.
Okay, so the rule is very simple. You have to be physically present within the room, and you can only win one gift for purposes of being fair to everyone. Okay? Shake, 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 shake. So the first gift is a Master 3 stethoscope. Can you pick one raffle? I can have my colleague Anne. Can you pick the gift and come with it?
And the winner here is Dr. Angela Nyam.
Okay. So we go back to our roots. We say they have to be physically.
Yeah.
So we do another raffle. Don't be tired. Keep it aside. I told you the law is very clear.
Okay, this one has to be here. The lucky winner is Bernard Odhiambo. Bernard Odhiambo.
Thank you, Dr. Cramwell. For the second gift is a portable vacuum cleaner. This one you can use it on your sofa, you can use it as well as in your car. And I will call upon Dr. Aisha to come and help me do the raffle. Dr. Aisha, kindly. Shake and pick one. So let's see who is the lucky person. So today is your lucky day. Just read out the name.
Muira S. Tasbai.
Thank you. Congratulations, Dr. Munira. Can you receive your gift? Have one photo. Thank you, Dr. Aisha. Gift number 3, a bagless vacuum cleaner. So this is a bigger version, the one you can use on the carpets, on the floor. And I'm going to call upon Dr. Joseph Nyakiamo to come and help me with that point. Karibu. So let's see who is the lucky person number 3. Can you shake, shake and pick one.
Emmanuel from Chogoria Hospital.
So Dr. Emmanuel wrote only one name. Can you read out for me your phone number, just to confirm? Great, it is him, I confirm. Thank you, thank you. Bagless the vacuum cleaner. Congratulations, Dr. Emmanuel. Thank you, and thank you for coming all the way from Chogoria. Great gift number 4. This is a blender to make your healthy juices, and I'm going to call upon Dr. Tara Patel to help me do the raffle. Karibu Daktari. Can you help me do the raffle? Spot on.
No waste of time.
No waste of time, right?
Dr. Darji, Shri Swaminarayan Hospital.
Congratulations, Doc. You win yourself a blender. It's big. You can even use it for commercial purposes. Thank you, Dr. Tara Patel. Congratulations, Doctor. Okay. Gift number 5. Here we have a toaster, a 2-in-1. You can make 4 slices of bread at a go. Make sandwiches. I'm going to call upon Dr. Samuel Michelle to come and help me do the raffle. Kindly, Doc. Shake, 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 shake. Take one. Let's see if the lucky person is going to win a twin toaster.
Okay, you won't believe it because the lucky person is me. Okay, the lucky person is Dr. John Degwa from Mombasa. Where is he?
Dr. John Degwa from Mombasa wins a toaster to make healthy sandwiches. He has Palm Beach Hospital. Great. Congratulations, Doc. Thank you, Dr. Michelle. Thank you, Doc. Gift number 6. We're all about eating healthy. We can make our fries with some little oil or zero oil at all. So we're talking about an air fryer. And to help me do the raffle, Dr. Joy Ogambi can help me do the raffle for a NutriCook 5.5 liter air fryer. You might as well.
So the winner is Edward Mutuku. I can confirm is Edward Charlo Mutuku. Nitumie M-Pesa ya 1 shilling.
Thank you, Dr. Shabani. And to all our winners, congratulations. They say we live to fight another day, isn't it, for those that didn't win today? So that gives us more hope. Thank you all for coming. Thank you for making this a success. And we'll look to make it even bigger and better. So I'll hand it over to my colleague, Evans. Welcome, Evans Korean.
Hello. Acha tu nisimame hapa kidogo. I feel the power. Yes. Good evening. Good. So good to see most of the faces I know whom I invited personally. Yeah. So we really appreciate your attendance for the first ever Care 360 in Africa. So I was first of all. I work as an area business manager for Zydus. So today, I'm just, as I said, it's a vote of thanks I want to give to all the speakers, starting with Dr. Shabani. As I will say, we'll go in reverse. So Dr. Shabani, thank you so much for your presentation on stroke management. You gave us a detailed analysis of the stroke risk factors and preventive measures, offering clear guidelines for our clinicians for positive patient outcomes. And clearly, those were, I'll say, master strokes, because we really emphasized on stroke prevention in the elderly. Because as you said, up to date, we don't have sufficient data of patients above. How many age? What was the age? Pressure increasing. So over 75 years of age, yeah? For those who are paying attention. Yeah, so we really appreciate that. That also, with your clear and practical management strategies which were clear and innovative. To Dr. Samuel Musheru, thank you as well. Your presentation in lipid management in terms of primary healthcare was enlightening and impactful. You gave us, what I'll say, a family medicine perspective by integrating that. So you gave us and highlighted that we need a personalized, tailored approach to every patient, offering clear guidelines for strategic lipid management strategies. So thank you so much for that. And also for the doctors who are present, but in absentia, I can see Dr. Angela, who gave us a very clear masterclass on atopic manifestations and how to manage these as clinicians to improve outcomes for better diagnosing and managing such manifestations. Dr. Mazaha Jafar, who really highlighted from his presentation. I knew I had some glimpses, but he was really emphasizing on antimicrobial resistance and the growing risk that it is, and what each and every primary care provider has a role to play in that, emphasizing that we need for more importance on vigilance, as well as responsible antibiotic use. So really appreciate him for that. Lastly, Dr. Peter Munu, by studying the relationships between atopic conditions and respiratory infections, he gave us a clear and roadmap, if I may say, on how to manage for better let's say better outcome efficiently. Okay. So with that, and last but not least, the lady of the hour, Her Majesty, if I can call her that, Dr. J. Mugambi, you've been with us through the beginning, since the first time we had the idea of orchestrating Care 360. So we really wanted to, as Zydus, to give you a heartfelt appreciation, from the initiation stage to here it has manifested. So really appreciate it for that, for chairing, and I know you are working together with Dr. Bramwell and Aisha. We really appreciate you also for chairing with Dr. Joy. We appreciate that so much. So you gave us quite a smooth execution, and your dedication definitely will have a lasting effect from today. Being the first one, can you imagine? The first one in Africa. So as Walter said, even next year will be bigger. Zydus Care 360 Conclave 2.0. Okay? So we hope to see all of you fresher, brighter, feel more puzzles, bigger prizes, right? Yeah? Thank you. You're looking so gloomy, but also. Yeah. So thank you so much. Okay. Walter?
Thank you so much, Evans. Allow me to quickly call Alexander Ombora. He's also our area business manager, who is quickly going to, you can see there's still some small consultation there. But Ombora is going to give us vote of thanks, then we'll just be finishing. Yes.
Habari zenu. My name is Alexander Ombora. I'm area business manager at Zydus. So first and foremost, as we get to the end of this conclave, I stand before you with a heart full of gratitude. And this couldn't have been possible without the contributions of very many people. So first, allow me to take this opportunity to thank KAFP, Kenya Association of Family Medicine. We are so grateful for partnering with us and providing us with scientific insights and visibility needed to make this event a success. And special thanks once more to Dr. Joy Mugambi. Thank you so much for your unwavering support. We highly appreciate your guidance throughout. Also allow me to take this opportunity to thank Dr. Jaffa Mazahir Jaffa. Thank you, Dr. Jaffa, also in the seat of this event. We appreciate your vision and dedication, which has been a cornerstone towards the success of this event. Also allow me to take this opportunity to thank our speakers. As Evans has mentioned them by their names, we are so grateful as Zydus. Thank you for the insightful presentations and taking your time to prepare them. We highly appreciate it. And then the doctors, all of you, bearing in mind that today is on a Saturday. Most of you could have had other places to go. We are so grateful for making time today. Thank you for coming, and especially for those who traveled all the way from outside Nairobi. We are so grateful for making time. Some of you we communicated to you sometime maybe less than a month ago. So some of you had to reschedule their patients to other days. We are so grateful for that, for making time to come today. And then to my team, our team at Zydus, you are the heroes. You've made this to be successful. You guys have worked around the clock, and we are so grateful that everything has been done in the right way. So thank you so much, Team Zydus. And then finally, allow me to thank Hyatt Agency Hotel for the hospitality, and also the tech team, EAN. Now I'm at EAN 254. Yeah, thank you so much for ensuring that everything will end without any glitches, and also to the branding vendor. So there's that team called 6 Ideas Limited. I'm not marketing them, I'm just appreciating them. Thank you so much for ensuring that the visibility was so clear. And then in conclusion, allow me to thank all of you for making this first ever Zydus Care 360 Conclave in Africa a success. And here's to many more in the future. Thank you so much. And finally, kindly ensure that as a sign of gratitude, everybody, as Walter had said, you will be given a souvenir bag. So as you exit the hall, kindly ensure that you pick one. Thank you so much.
Thank you so much, Alex. And one last more thing that has remained. There's still some doctors that we need to appreciate for the wonderful coordination that they have done. The gifts are there, and to have this, we want to, in Africa, when your dad is there, it's good that we want to acknowledge. Just right at the corner there, we have Mr. Vinitsha. He was here in the morning. He's our vice president, head of Africa Cluster. I want to call him so that he can award, just gift these doctors who have really taken their time. Mr. Vinich, you should be here. Such a great honor to invite you. And after that, I want to do 2 things. We'll just be able to stand up and finish. We have tea at the where we took our tea, and after that, you can take plenty of photos, and then we send to you, right? Thank you so much, Vinich.
Okay, so we'd want to appreciate 2 doctors who came out really well today to support all of us and to support specifically Dr. Joy Mugambi. So Dr. Aisha, kindly come. Thank you for plugging in today and for chairing the mid-morning session. We appreciate your inputs, your efforts. You can come down for photos. Asante sana, Dr. Aisha. And we look forward to continue partnering together. Thank you. The next doctor who also came and plugged in, Dr. Bramwell, Karibu. Thank you for blessing us with your time, with your effort. We indeed appreciate you. Asante sana for being part of this conclave today. Next in line, this is a doctor we've walked through this journey of preparing Care 360 this year. He was one of the faculties and the speakers today. Dr. Samuel Moshero, we really do appreciate you, your time, your guidance, your input into making this a success. Thank you very much, Dr. Samuel Moshero. Thank you very much, Asante Sana Daktari. Next, this is an ardent Arsenal fan and supporter. Once I say that, most people will know. Asante Sana, Dr. Jacob Shabani, kindly come. We also appreciate the role that you play as a senior to all of us. For the in-depth science that you continue to guide us, we did say Asante Sana. Thank you very much, Dr. Jacob Shabani. And lastly, we would want to appreciate a very special person to all of us. She's been the mom who has holding us together in the journey of preparing this Care 360. So kindly help me in welcoming and thanking Dr. Joy Mugambi. Thank you very much, Dr. Joy Mugambi. You have also been with us since the very first day. We appreciate all the effort you've put in, your time, your dedication, your guidance into making Care 360 Conclave 2024 a success. So I'll just allow Mr. Winit to do a brief closing remarks, and then you'll welcome Dr. Joy Mugambi to close for us. Thank you.
Closing remarks that are supposed to be very brief. Thank you very much, everybody. This was a wonderful day spent. Thank you.
Thank you very much, Vinette. This is a very emotional day. It's been a journey of lots of evening meetings, lots of arrangements and plans. But there was a team that really worked hard to ensure that this is a success. And to our dear members in KEFP, when you come up with a project, we'll support you. Jaffa was the brain behind this project. They met with Zydus and they came up with a plan. They reached out and we supported him, brought together the faculty, and the faculty was really key. They sat through meetings at odd hours. Sometimes I was not really able to attend all meetings, but we did planned through WhatsApp, planned through Zoom meetings, and it came to fruition, and it's been a success. Has it been? Have we learned? Have we networked? Today I've gotten to know new people, met old faces, and I look forward to engaging going forward. We'll have such fun times through the year, and we'll have lots of other webinars that we look forward to work with you. Family medicine is one of the largest programs in the country. It has 5 institutions that offer family medicine, not just Aga Khan. Most people think it's Aga Khan. Aga Khan is one of the younger babies. We've got Kabarak, where I teach in Nakuru, and Bramwell is a product of Kabarak. We've got Maseno. We've got Moi, one of the oldest programs in this country. We've got Kenyatta University. You had someone back there from Kenyatta University who's a resident. And have I left one more? No other. So please, if you're a medical officer, we'll want you to join us. We've also got programs out there outside, inclusive of Aga Khan Dar. I got to know Shabani from Aga Khan Dar es Salaam. I did my undergraduate in Tanzania, and Aga Khan used to be the place where we used to go for treatment. Na kulikuwa na mkei, alikuwa anajulikana. Mkei alikuwa nani? Shabani. That's how I got to know about family medicine many years back in the early 2000s, late 1990s, early 2000s. So Shabani si kijana, huyu ni babu, tunamuita babu. So Dr. Shabani has mentored many of us, has walked the journey. I came back after doing my undergraduate, which I was doing after doing clinical medicine. Where are the clinical officers? If we have them. I started off as a clinical officer and then went to do my undergraduate after some work in Kenya. So it's been a journey of 1,000 steps, but we are here today and we are happy to be continuing the journey of advocacy and support to others who would want to join medicine and do very many things. And then learn, continuous learning. We've dedicated today completely to learn and to support each other so that we grow. So reach out to anyone around here. If you want to join any residency program in family medicine, we'll support and we'll mentor you and we'll journey. So from this meeting, I've learned quite a number of things. One, we need policies to address all the gaps that we have talked about. We need standard operating procedures. We need guidelines. We need to adhere to the essential drug list so that we do not lose out the valuable antibiotics we have. And with that said, as we go back to our workplaces, let's go with one reminder from Babu, Shabani et al. It is not easy to take medication for diseases that don't cause pain. That was what actually touched my heart completely.
So anyway, the mic is gone off, but I think I have a loud voice. That's my take home. Shabani said, if you don't have
pain, you don't commit to taking your medication. Let's hope hypertension and diabetes won't be painful, but we commit to taking our medications, even if we are aging, we are growing. But let's look for ways, innovative ways to ensure our clients take them. Thank you all of you. Thank you, Zydus. Thank you so much for coming today. We look forward to 2024 Care 360 2.0. Bigger, better. Thank you.
So it's a wrap. Thank you for being with us from morning till the evening. We look forward to continue working together out there in your places of work, in your places of practice. And for those who are traveling, we want to wish you very safe journeys. And for those who remain in the city, tunaendelea na mapambano, si ndio? Great. So as you go out, kindly pick a bag at our booth. And for those who came with your cars, kindly remember to value at the 8th floor. All the best. Have a lovely evening and a great weekend. Asanteni sana.